Bismillahirrahmanirrahim. Assalamu alaikum everyone. With Allah's name, I start with the most beneficent and the most merciful. I welcome you all to the second session of this rheumatology review course of the Silver Jubilee 25th Pakistan Society for Rheumatology International Conference. In the second session, just give me a second. Okay. In the second section, our chair will be Professor Nigat Mir Ahmed. She is the Professor and Associate Dean, Institute of Rheumatic Diseases, Central Park Medical College. She is also the Chair, Department of Rheumatology at National Hospital and Medical Center. She is Director and Consultant Rheumatologist at Arthritis Care Center, and she is also the Adjunct Faculty of Fatima Jinnah Medical University, Chair and Founder Trustee of Arthritis Care Foundation. She is a pioneer in developing the first training program of rheumatology in Pakistan, recognized by College of Physicians and Surgeons, Pakistan. She is also the founder, trustee and chairperson of the Arthritis Care Foundation, which is actively involved in both supporting patient care for the needy and giving education and training in the field of rheumatology. She is one of the best past presidents of Pakistan Society for Rheumatology and a true mentor. She was awarded Masters of ACR Award by American College of Rheumatology in 2019. Welcome, ma'am. Our co-chair is Professor Dr. Muhammad Ahmed Saeed. He is the Professor and Head of Department of Institute of Rheumatic Diseases, Central Park Medical College. He is also a consultant rheumatologist at Arthritis Care Center and adjunct faculty of Fatima Jinnah Medical University and co-founder of Arthritis Care Foundation. I, being a trainee of both these great people in the specialty of rheumatology in Pakistan, it's an honor for me to moderate a session in which they are chairing and co-chairing. They are both true mentors, and I'm grateful to both of them. I'll request one by one, first Professor Nigat Mir to have a few words, and then followed by Professor Ahmed Saeed.
Thank you so much, Bilal. Bismillahirrahmanirrahim. It's a pleasure, it's an honor to be chairing this session. What a star-studded program you have. And hats off to Saira and Bilal and the whole PSR team, which is standing behind you. And what an excellent program. I have no words to, express my appreciation. And look at the first session, which was so well attended. And mashallah, we learned so much from that. And now, look at these names, Professor John Kirsch, Michelle Petrie, and Kelly Breeze here, and Tom Appleton, and John Stowe. You have like the galaxy of the globe here, and I think we are very fortunate that sitting at home, everyone can listen to these great talks and learn from them. My congratulations and for your putting up such a great program, and thank you so much for whatever you are doing right now for rheumatology, obviously, because it's a great learning experience. And I'm so proud of you, Saira, Bilal, being your mentors and your teachers. I think nothing can make us more proud than what you are doing right now. Ahmed, what do you have to say?
Thank you, ma'am. Dr. Ahmed, over to you.
Assalamu alaikum and a good evening to everyone. So it is really a great pleasure. So what a great start of the 25th Silver Jubilee Conference. I really appreciate that Saira and Bilal have actually put up this show all alone. I would say these two youngsters, they are, I believe, the second or the third generation of rheumatologists in Pakistan, all trained at the center. We were working together. I'm really privileged to be part of their training, and it is really so heartwarming to see future leaders. So we can say that the future of rheumatology in Pakistan is in secure hands. So congratulations, team.
Thank you, sir, for your great words.
Line of speakers you have. So indeed, it's such a pleasure listening in the morning session, and these are all stars of rheumatology. These are the ones for whom we actually fly across the Atlantic to go to ACR and ULA to hear these iconic stars in the field of rheumatology. And we are grateful that they have given us time, a very precious time for Pakistan Society for Rheumatology 25th PSR Silver Jubilee meeting. Thank you, everyone.
Thank you. Thank you. Thank you so much, Professor Nigat and Professor Ahmed Said, for your kind words. Now we'll start with the first talk of our second session. The first talk is by Professor John Jack Cush. He's the professor and executive director at rheumnow.com from Dallas, Texas, and he would be speaking on adult onset Still's disease.
Hello, everyone. I'm Jack Cush, executive editor of rheumnow.com. It's a pleasure to be with you here at the Pakistan Society of Rheumatology, especially on this Silver Jubilee event. I've been asked today to talk about my favorite subject in rheumatology. I hope it will soon be yours, and that is, of course, adult onset Still's disease. Let's get started. So, Still's disease is a challenge for many of us. We see patients who are presenting with fever. They're often quite ill. And the question is, how do you diagnose this? What are the considerations in diagnosis, and how to move forward with regard to new therapies? So these are my conflicts, or some of the potential conflicts. My only reasonable one here is I have been a consultant to Novartis, who has an FDA-approved product for Still's disease in the United States. That's canakinumab. This is the first case of Still's disease I saw as an internal medicine resident in 1984. A 23-year-old gal presented with a 3-week history of fever, sore throat. She was having diarrhea, abdominal pain, arthralgias, and you can see these are the fevers. Spikes that she had during the first 2 weeks, as high as 105. It was associated with high sed rate, high CRP, high white counts, ranging from 20 to 40,000. Obviously, after exclusion of other etiologies, this wasn't a hard diagnosis, even back then in 1984. And I'll remind you, the condition really only had been described in 1971. The question is, how do we make the diagnosis? So that's a question to you. Can you make a diagnosis of Still's disease with a test? Can you confirm it with a test? I left out the word test on this question. And the answer, of course, that you have to choose from is yes or no, true or false. And the answer is false. There is no confirmatory test that one can order to diagnose this condition. I want to confirm that. There is no diagnostic test. Still's disease is a systemic inflammatory disorder. It's a syndrome, and as it does not have a clear etiology or diagnostic test or pathology, it is therefore a syndrome that you make after considering the presentation and excluding some other conditions. It's typically, as you know, a juvenile disorder, systemic juvenile idiopathic arthritis, SOJA or SJIA. But when it continues beyond age 16 up to age 35, you should consider something like adult Still's disease. Its key symptoms are quotidian fevers, evanescent rashes, polyarthritis, a sore throat that's prodromal, meaning it happens at the onset, serositis, organomegaly, high white counts, and very aggressive, very marked elevations of sed rate, CRP, and other acute phase reactants, of which ferritin is only one. So in some, this is a diagnosis of exclusion. The disease itself has a systemic onset, and then it can go into remission and then have systemic recurrence. We could call that a polysystemic or polycyclic systemic. But some patients will develop the onset of systemic disease followed by chronic inflammatory arthritis. Either way, this condition can give you long disease-free intervals. The longest one I've ever seen is 40 years. The patient I just showed you, the 23-year-old, she was sick from ages 9 to 12 with an undiagnosed febrile illness, which in retrospect was systemic JIA. So she had a 11-year disease-free interval before the disease came on out of the blue quite suddenly. If you consider systemic JIA and the adult continuation of the disease, adult Still's disease or adult onset Still's disease, all the manifestations are exactly the same. There's probably only one, and that is the prodromal sore throat, which is part and parcel of the adult presentation, 70%, but is uncommon in kids, and the reasons for that are not entirely clear. It's also not entirely clear what that sore throat is. Is it an initial infection that might have been the activator of the inflammasome and aggressive NLRP3 response with lots of IL-1, IL-18? Or is it just a manifestation of lymphoid hyperplasia reactivation, and that's what gives you the sore throat from lymph node tissues? And there's evidence of that too. We really don't know. This is a long history, and condition bears the name of George F. Still, who in 1897 described 22 children who had a form of chronic arthritis, a subset of whom had systemic features like weight loss, lymphadenopathy, anemia. They did not describe the high fevers. They did not describe the rash, which is sometimes called the Still's rash. That was described by Boldero and colleagues in 1933. Otto Moltke actually was the first to describe Still's disease in the adult in the Scandinavian literature in the same year. But over the years, this disease has been around. It just called different things or not called the right thing. The French literature called this the Whistler-Fanconi syndrome or subsepsis hyperallergica. It wasn't until these two key seminal papers in 71 and 73 by Eric Bywaters at Hammersmith in the UK and Joseph Bujak at the NIH described 14 and 10 patients, female and male respectively, that really classify this disease incredibly well. And I want to stress that to you, that those two papers are probably all you need to read if you want to understand Still's disease. So the original Bywaters paper, 1971, Annals of Rheumatic Disease. The paper by Bujak was a series that published in the Journal of Medicine. If you look at these two reports, and by the way, they're not like current reports. These are very descriptive case reports. So it's like, 10, 12, 18 pages, something like that, to read through the cases. But that's how you really get to understand this condition. Early on, the Bywaters report, it was all females. Later on, Bujak was all males. Turns out it's equal between the sexes as to who gets affected, both in kids and adults. Again, this is the adult continuum of the juvenile disorder, hence it's less common in adults than it is in children, but yet it behaves the same. Once you start making this diagnosis after age 35 or after age 50, you're on your own. It's probably not going to fit. You must have, and a subset of these people actually have a prior history of systemic JIA, as did my patient that I presented at the outset. You must have the triad here, the quotidian fevers, the rash that comes and goes, the polyarthritis. That's almost required for the diagnosis for you to seriously consider this diagnosis. Many of you make this diagnosis because you have an undiagnosed fever, some systemic manifestations, and you're a rheumatologist. Well, that would be the wrong thing to do, right? You need to actually meet criteria, which requires these three. Other features I've already mentioned to you, and they were prominent in these two case reports. This is the fever that was in the Bywaters paper. It's spiky, it's up and down. It returns to baseline, meaning below 99 every day. That is what is the definition of a quotidian fever is. This is a very common disorder. If you work in a major medical center, you're going to see one or two of these a year. Based on the epidemiology, what we know, the incidence rate is about 1 case per 100,000. And in my city of Dallas, Texas, we can expect to see almost 19 to 20 cases per year with Still's disease. Yet, even though I'm like the self-declared world's expert in Still's disease, I don't see 19 cases a year, and I should be. They kind of end up in a lot of different places and maybe not in your hands until it's too late. As you can see, as I said earlier, this is the adult continuation of the juvenile disorder. So mostly in the 20s, some in the 25s, 30s, a few in the 30s. After age 35, you see very few cases. After age 50, 9% of cases were going to have Still's disease. Now, more recently, many people are starting to make this diagnosis in the elderly. I guarantee you they're incorrect diagnoses. They're not based on criteria. They really have no long-term follow-up. I think these are very rational, reasonable numbers. 75% of cases will have their onset before the age of 35. So again, I can't stress enough the triad. Fever of greater than 39 degrees centigrade, equal to or greater than, and also or 102 degrees Fahrenheit. Evanescent rash means it comes and goes. It changes day to day. That's about the main description there. Polyarthritis, it can look like rheumatoid. It can have small joints, large joints. It can be symmetric. It can be progressive. It'll stay progressive in some subset of patients. Let's get into the triad symptoms and describe those a little better. Quotidian fever means it rises above 102 Fahrenheit or 39 degrees centigrade and then returns to baseline. It happens once a day. The amazing thing about this condition is it happens at the same time every day. It's never in the morning. Morning is when you have your highest levels of endogenous cortisol. So if you see fever at 7 a.m., you're dealing with infection or malignancy and not Still's disease. It's incredibly rare. The spikes of Still's disease that happen at the same time in every patient every day are usually late at night, 10 to 2 a.m., or late in the afternoon, 4 to 5, or occasionally late in the morning, 11 to 12 in the morning. And then it repeats it again tomorrow. The patients can look at the clock and tell you when it's going to happen. And it happens first with a shaking chill, rigors like you can't imagine. And then they throw off all the covers because they get this high spike and they go up to 104, 105 degrees Fahrenheit. And when it starts to come down, they defervesce. So when you see them on morning rounds, they may look normal. They may not look as sick as they were last night. There's a few more examples of the high spiking fever, both from the Bywater's paper and my original case. You can see my original case actually has a high baseline. That's called a remittent pattern, a little less distinctive here, but usually a little sicker patients. When you start to give anti-inflammatory therapy, salicylates, and then later on steroids, you start to see the more typical pattern of daily spikes, or going from twice daily spikes to once daily spikes, and then going from daily spikes to intermittent spikes or lower grade fever as you start to add in steroids, etc. Rash, the evanescent salmon pink rash, is also called a rheumatoid rash or the Still's rash throughout the literature. It does change day to day. It does tend to be maximal or most likely to appear during febrile time points. It is a faint erythematous salmon pink in some people. It can be macules and papules. It can have confluence. It really does look like a viral example. It's a viral morbilliform looking rash. It never happens on the face, never happens on the palms or soles or hands. It is an extensor extremity and truncal and V-neck rash. It can have the associated features of dermatographism and Kebner phenomenon. Kebner phenomenon is what you're seeing here on the right. This young man has been scratching his abdomen, so when the rash comes, it comes as isomorphic lesions along the lines of former trauma. And Kebnerization is if you take a pen and you scratch the skin, you get a wheal and flare that takes a long time, an hour or more to go away. Urticaria and pruritus is very common. 40% of patients with Still's disease, kids and adults, will have urticaria or pruritus that can be intense. This is a common feature amongst the autoinflammatory syndromes. So don't believe because of this, it can't be Still's disease. As I said, uncommon is rash on the face, palms, soles, dermal plaques. Alopecia, enodosum, Raynaud's has been described, but these are rare. Here's some pictures. This is a patient of mine who has a rash almost in a V-neck distribution. She did not have myositis, right? You can see over her right shoulder, she has a wheal and flare of dermatographism where she scratched herself. And that's actually, it could be Kebnerization as well. But again, maculopapular. Here's another one, that same man I just showed you, a young adolescent. He has a protuberant abdomen from hepatomegaly, and he has a rash that comes up with fever. Here's a patient of mine with a faint rash over the anterior chest that's more faint red or pinkish. Let's talk about the arthritis, which is true about joint involvement in Still's disease. Oligoarthritis is more common than polyarthritis. Your second choice, sacroiliitis in 10%. Third choice, seropositivity leads to erosive polyarthritis. Fourth, 10% develop an erosive polyarthritis. And 50% develop carpal ankylosis. Answer down. The answer is half of patients will develop carpal ankylosis. About a third of patients, 25 to 30, 33%, will develop a chronic polyarthritis that'll look like RA, right? And maybe half of those will be erosive, but we don't have firm numbers on that. Sacroiliitis doesn't happen. Oligoarthritis should make you question the diagnosis. Seropositivity is not part of this condition. They're supposed to be seronegative by definition. So common features at the outset are arthralgias, myalgias, but they should evolve into arthritis within the first 3 months. It's usually additive and polyarthritis. The graph on the right shows you the onset. On the left, what happens in the first 6 months. This is taken from the paper that I wrote with Tom Metzger in Pittsburgh on 21 patients. So you can see on the left, 18 out of 21 had wrist involvement, 14 elbow involvement, 11 shoulder involvement, 11 and 10 with PIP and DIP involvement. And then over time, it settles down in the course after 6 months to wrist, knees, shoulders, hands, etc. Right? So it looks like RA. But half the patients will develop what Metzger and Christie described as pericapitate ankylosis of the wrist. So the capitate will fuse to the hamate, to the trapezoid, to the second and third metacarpal base, and or to the lunate. And here's an example. This is a patient of the famous Gerald Rodman of scleroderma fame. He saw this man, LK, in August of 72, normal wrist, although he had wrist pain and wrist swelling. 7 months later, you can see there's evidence of carpal ankylosis, where now the capitate is fused to the second and third metacarpal and also to the lunate down here in the bottom right. This is very typical. And again, if you look for it, it takes time in some patients to evolve. It's not usually as aggressive as that particular case. So about 2/3 of patients will have sore throat and weight loss and myalgias. The RES, reticular endothelial system, is involved with hepatosplenomegaly or LFTs, elevation or lymphadenopathy in almost 2/3 of patients. Serositis in around 30 to 40% of patients. I had a patient on the bottom right there who had not only pleuritis, pericarditis, he had myocarditis proven by endomyocardial biopsy. He was 19 with a temperature of 104, and he had splenomegaly, and anyway, he also was diagnosed with Still's disease and treated aggressively. The labs are often as distinctive as the clinical features. They should be seronegative, but they have high white counts. Their hematocrit and hemoglobin drop dramatically. They have very high sed rate CRPs and platelets, reflecting the acute phase response. And as they get more and more inflammation, what will happen? Their albumin will drop in response to excessive IL-1, IL-6. Their anemia will become more prominent. Their hemoglobin goes down. And then they lose weight. So the albumin, anemia, and weight loss will all parallel each other in patients who are actively sick with systemic manifestations. Ferritin, which all of you love, is only seen in half the patients. So to hang your hat on a diagnosis on ferritin is a big mistake. Look at the upper right. The distribution of white count is generally 15 to 25,000. Look at the bottom right. The distribution of sed rates. 90% have a sed rate greater than 50. 50% will have a sed rate greater than 90. So again, you can have sed rate or CRP or other acute phase reactions, but generally they're all up. Now, ferritin, let's not get carried away. There are other causes for hyperferritinemia. I've seen a lot of hyperferritinemia. I've seen over 200 cases of Still's disease in my career. And I can tell you, I have about 10 or 15 really good, greater than 10,000 ferritins. So I've seen way more ferritin in other diagnoses like lupus and vasculitis. But you should consider iron overload cases, intrinsic liver disease, cancer, sepsis. And then what worries me most is when I see extreme ferritins, I'm really looking at the development of macrophage activation syndrome, also called the hemophagocytic syndrome, which is quite common in kids and adults with Still's disease. Just look at the right. This is one series that shows you with active disease, the mean ferritin's around 4,000. With inactive, it goes away. The bottom right shows you 10 kids with pediatric or juvenile systemic JA who started out with ferritins generally around 1,000, and then with time, they slowly got better and came down with therapy. That on the bottom represents weeks, not days. So the patterns of involvement here, everybody starts out with systemic disease, meaning arthritis is usually not the component that starts here. And by systemic disease, I mean fever, rash, pleuritis, crazy looking labs, etc. It goes away and some people never comes back. That's B monosystemic. In our collection of 21 patients in Pittsburgh, 4 out of 21 had one spike. You can see that 2 out of the 21 had polysystemic with disease-free intervals. And then on the bottom two graphs, you're seeing either monosystemic or polysystemic disease with chronic arthritis, usually inflammatory arthritis that looks like RA. That's 15 out of the 21 patients. Mortality in stills, there is no mortality in stills. You're not supposed to die from systemic JIA. You're not. If you do, it's because you develop macrophage activation syndrome or because you used too much steroids and killed them with steroids, meaning that they got opportunistic infections and died from that. I've seen more deaths in Still's disease from like car accidents and unrelated things. I've had a few patients die from amyloidosis and renal amyloidosis. But again, the main complications here are steroid complications, MAS, steroid-related infections. DIC and chronic lung disease have been described, but they're not very common. So who can diagnose Still's disease? First off, kudos to pediatric rheumatologists. They know what they're doing. They see a lot of these cases. This is not hard for them. They know what to exclude. They know how to manage them. Adults, we don't see quite as many, which means I think you adult rheumatologists should be talking to pediatric rheumatologists about your difficult cases. They can help you tremendously. Most of us adult rheumatologists get these cases handed off to us from infectious disease consultants. Patients admitted to the hospital, high fever. There's a big ID workup. When the ID guys are done and say, nope, no bacterial, no viral, no fungal, no parasitic infections, it must be Still's disease or systemic JIA. Call the rheumatologist. And if you're a rheumatologist, you can be certain about the diagnosis by knowing the criteria. What are the criteria? Well, before we get into criteria, let me give you my 5 top mistakes that I've seen. Again, I've seen many, 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 many cases. I've seen a lot of misdiagnosis. The number one mistake that rheumatologists make is making the diagnosis without the presence of the triad: evanescent rash, quotidian fever, polyarthritis. This is always included in the criteria. 2, not having a daily quotidian fever or not reaching 102. Patient says, I get a fever every day of 101. Sorry, Charlie, that's not Still's disease. Number 3, they have fevers that come and go. I had it for 2 weeks, I had it for 3 days, then it went away, or it comes back every Friday, Saturday, Sunday, or it comes back every spring, or it comes back. That's not Still's disease. That's likely another autoinflammatory disease, usually monogenic, and can be diagnosed with a battery of gene tests that you can get through next-gen sequencing, usually for a reasonable cost. More emphasis on the ferritin to make the diagnosis. You will miss more than half the cases if this is what you're hanging your hat on. And lastly, using a TNF inhibitor disease that doesn't work where it doesn't work, meaning TNF inhibitors do well in the patients with Still's disease who develop chronic arthritis. You're just basically treating RA. But if they have systemic disease and they're being newly diagnosed in the hospital, do not use a TNF inhibitor. They don't work. And I know you'll tell me, I saw a paper once. Yeah, it was from 15 years ago. In the recent ACR guidelines in the treatment of JIA say you can use an IL-1 inhibitor at the outset. First, make a diagnosis. These are my criteria. I came up with them when I was first working on this in 1984. I published this in 2000. You get 2 points for having what I think are the highly predictive features of the disease, very discriminatory. And if you have 10 points, you're likely to have the diagnosis: quotidian fever, the Still's rash, simultaneous elevation of white count and sed rate. Can I have both? And I would accept white count and CRP, or white count and another acute phase reactant, seronegativity, and carpal ankylosis. Now, carpal ankylosis is not present at the outset, but in some, you may be seeing them later in the course. And of course, this would be any time during their course of illness. You get 1 point for minor features: age less than 35, polyarthritis, sore throat, LFTs or hepatosplenomegaly or lymphadenopathy, serositis, and ankylosis somewhere else. There's Yamaguchi criteria that are often talked about. This is from J. Room. They also rely on a major minor motif in making the diagnosis. I don't expect you to know these or write these down, have them in your pocket. All you need to know is a website that I built for you called Stills Now. Sounds like Room Now, but it's Stills Now, as you can see in the upper left. And Stills Now, on the first page, is going to say, do you meet criteria? You click on this button, it'll take you to the criteria page. On the website, there are videos that will cover a lot of stuff that I'm talking about here in greater depth. There's a lot of news and journal reports. There's reports and resources for your patients, what to do when it's not Still's disease, best drugs for Still's disease, laboratory diagnosis of Still's disease, etc. So again, it's a valuable website, stillsnow.com. If you click on the calculate my risk, you can calculate whether or not you have the diagnosis. And you basically check boxes on symptoms that are present now or at the onset. And the website will tell you whether you meet Cush criteria, Yamaguchi criteria, or ILAR criteria. I think you'll find it useful, stillsnow.com. How do I assess activity? Basically, sed rate, CRP, white count, and LFTs are what I watch most closely, right? And those tell me how active the patient is. If they just have arthritis, it's what you would normally do for RA. But if they have systemic disease, the simple things work really well. And you can see on the right, in this one study, it showed that more predictive than ferritin, sed rate, and CRP is NLR, the neutrophil to lymphocyte ratio. It's usually quite low, but if it's greater than 3, they're very inflamed. If it's greater than 5.86, they're at high risk for macrophage activation syndrome. The other thing I'll tell you here that you'll see nowhere else is highly valuable biomarker is the aldolase. Not CPK. You can do CPK and aldolase. The CPK will be normal, but patients who have an IL-1 driven autoinflammatory disease or Still's disease or systemic JIA, the aldolase will be high when they're active. And you can use that as the biomarker to know whether or not they're in remission or doing well or not. More recently, there's another report about myeloid-related protein 8/14. That looks very good, but that's too early to know where that's going to go. How do you treat this? When I asked rheumatologists in a survey of almost 250 rheumatologists, after steroids, what would you use? Half would use a biologic and half would use methotrexate. They're both right. But again, the recent guidelines from the ACR say it's okay to use an IL-1 or IL-6 inhibitor. So everybody should get high-dose steroids. Non-steroidals can be a little bit troublesome in patients who have LFTs. Steroids, and again, don't be wimping out with 5 milligram, 10 milligram, 20 milligrams. That doesn't work in Still's disease. If it works in your case of Still's disease, it's not Still's disease. Still's disease requires 1 milligram per kilogram, 60 milligrams a day, rarely 40. And then you need to, if you're going to use that kind of dose, you need to put them on either methotrexate or an IL-1 inhibitor or IL-6 inhibitor. I like IL-1, short half-life with anakinra of 6 hours. I give it at night because your own endogenous IL-1 and IL-6 are circadian cytokines. They come up late at night when you get the fevers. So give the IL-1, which has a short half-life, at night, QHS dosing. And you can use IL-6 as well, but it's a little slower to start, but it will work certainly just as well and maybe even better in patients who have problematic arthritis. There may be a role of calcineurin and JAK inhibitors, but it's hard to say. So FDA-approved therapies in the United States for Still's disease in adult, it's canakinumab only. In Still's in children, it's for canakinumab and tocilizumab. Look at the package insert on that. I'll flash up this slide for you. You can take a picture of it. It'll tell you about the dosing that's used in the different conditions for which it's approved and the half-life of this. Again, I like anakinra because of its short half-life. After a patient has done well on this with QHS dosing, then I may switch over to canakinumab at some point. The question is, you don't know how long to treat these patients. You don't know when they're truly in remission. When patients ask me, how long is this going to last? I say either 8 months to 8 years, and we'll know it when we see it. So show me a year or at least 6 months of remission, and then we can talk about maybe withdrawing therapy. The IL-1 inhibitors do have a higher risk of injection site reactions, 71% supposedly with anakinra, 48% with rilonacept. But I want to make the point that when the patient is transitioned from systemic disease to articular disease, you manage them, like it says in this blue box, just as you would RA. Methotrexate, TNF inhibitors, abatacept, IL-6, combinations, JAKs, they all work incredibly well. The real challenge is treating MAS, macrophage activation syndrome, of which you have several options. MAS can occur in up to 10% of kids and adults, and I would worry about that. We talked about complications earlier, polyarthritis, DIC, carpal ankylosis, lung disease. We don't know what the etiology of the lung disease is, and it's really quite rare. Amyloidosis does occur. I've had 2 patients, as I said, who died with renal amyloidosis with Still's disease. But cytokine storm is the same as, and a cytokine storm being infamous during COVID, It's the same as macrophage activation. It's the same as HLH. All these patients have sudden high fever, hypotension, CNS manifestations. They take a turn for the worse. And it's exemplified by extreme levels of ferritin and rapidly rising LFTs, AST and ALT more so than alk-phos. They develop a pancytopenia. So when they once had a high platelet count and a high white count, they are taking a turn for the worse and they're bottoming out if you don't catch them soon enough. It has all the same biomarkers as does cytokine syndrome. I want to tell you that, again, the hairs on the back of your neck should stand up when you see a patient whose SED rate is dropping when it was once high, whose white count was dropping when it was once high. And now the CRP and the ferritin are going even higher. This is macrophage activation. The earlier you make the diagnosis and intervene, even if it's not complete, and there are criteria for this that I don't think are worth your looking up, you should treat if you suspect. By the way, hemophagocytosis on bone marrow is not required for the diagnosis. If this occurs in kids, the mortality here goes up to 20%. In adults, the mortality here has been as high as 38%. What do? You start them on high-dose steroids, very high-dose steroids, 2 milligrams per kilogram, split doses. Start them on an IL-1 or an IL-6 inhibitor. And if you have access to something to inhibit T-cell activity and all these cytokines that are being generation, emapalumab or cyclosporin is what I prefer. The etiology of this is shown on the right. NK cells and dendritic cells, under the right circumstances, now are activating CD8 cells, and you have tons of cytokines being produced. The main one that drives the syndrome is gamma interferon. Emapalumab is a gamma interferon monoclonal antibody therapy that works incredibly well. But by targeting T cells with cyclosporin or etoposide, you're cutting down on the plethora of cytokines that are driving MAS. Let's summarize. Stills in kids and adults are the same. It is important that you confirm the diagnosis by finding the triad and looking for the other suggested features. Know the criteria. If you don't know the criteria, know the website, stillsnow.com, and that'll teach you how to make the diagnosis. If they're atypical, at all atypical, then you really have to question the diagnosis. If they don't meet criteria, question the diagnosis, and then start to do gene testing. You know, if you live where FMF is prevalent, test for FMF. And again, you can make the diagnosis there on the number of days of fever. You know, something like FMF or some of the CAP syndromes will have a few days of fever, right? Whereas something like TRAPS will have 10 days to 20 days of fever, and then it will go away. But gene testing is important. You have to consider, besides autoinflammatory conditions, infection, leukemia, lymphoma, and that's, I think, takes care of most of the cases that get confused with Still's disease. Worry about MAS, use IL-1 and IL-6 inhibitors liberally, and tell your patients this is not something that goes away in a few weeks. 8 months to 8 years, and luckily, some will go into long-term remission. I hope you find this valuable. If we don't get to do questions here, I'd be happy to take your questions by email at jackcush@rheumnow.com. Enjoy the meeting. Take care.
Thank you so much, Professor Kush, for such an excellent and very detailed talk on Still's disease. I would like to remind all of you to please post your questions in the Q&A section. Now we move on to the second talk of our second session. This talk is by Professor Michelle Petrie. She is the Professor, Division of Rheumatology, Department of Medicine at Johns Hopkins University, and she is the Director of Hopkins Lupus Center and a co-director of Hopkins Lupus Pregnancy Center. And she would be talking on updates in renal lupus.
I want to thank you for the invitation to talk with you on lupus nephritis. Here are my disclosures. I don't think you're going to find any of them relevant. And my objectives are to discuss the impact of lupus nephritis, consider our current treatments, but really to talk about a new paradigm that includes the newly approved treatments. First, the impact. So in my patients who develop lupus nephritis in the first year of their lupus, within 20 years, 23% will be in end-stage kidney disease. The risk is highest in those who are men, African American, and those diagnosed at an early age. And in fact, in pediatric lupus, lupus nephritis is almost universal. Of all the serologies, a low C3 is the strongest predictor. This is a landmark study that was done by Michael Ward using the U.S. renal data system. And you can see some very disturbing trends here. There was no improvement in end-stage kidney disease due to lupus nephritis up until 2004. And this doesn't make a lot of sense because we knew about mycophenolate and we're using it. And of course, because the United States is a multi-ethnic society, we do know that lupus nephritis and therefore end-stage kidney disease are more common in African Americans and Hispanic Americans. Here are the more recent data that were presented at the ACR plenary session last year. This is a study showing a downward trend in mortality from lupus nephritis up until about 2008, and then very disturbing, an increase occurring from 2015 till 2020. This was all before COVID. So why on earth were the deaths going up? Again, in the mycophenolate era. I think one issue is one that was brought home to me after listening to a lecture from Professor Anders, a German nephrologist. And his theme was that nephrons, once lost, are gone forever. At the very first episode of lupus nephritis, our patients have lost 1/3 of their nephrons. So lupus nephritis should automatically be considered chronic kidney disease. Now, because the remaining nephrons hypertrophy, we often aren't aware for some time because the GFR looks like it is preserved. Now, of course, in you and in me, we're going to lose our podocytes and nephrons as we get older. So on his figure, we are that blue curve. But we'll get to 100, hopefully, and not be on dialysis. Now, there are two red curves. That middle curve shows the patient who does beautifully. She's diagnosed with lupus nephritis, but she gets into a renal remission very quickly and never has a flare. She should make it to about 85 or so before she's on dialysis. The problem is that's not real life. The bottom red curve is real life. Our patients have that initial deep dive, and then it takes a long time to achieve a remission. And unfortunately, most of our patients will have a renal flare and then once again lose 1/3 of the remaining nephrons. So his message is most of our patients will be on dialysis by age 70. So what's our goal? Well, of course, we want successful treatment of lupus nephritis, but it's going to be essential for the patient never to have a flare. We need to check the spot urine protein to creatinine often so we can detect when the urine protein starts to go up, and we must consistently check on adherence because most lupus renal flares are because the patient has stopped her tablets. And then, of course, we must think the way nephrologists do and not put the remaining nephrons at risk. So no NSAIDs, no CT dye, no proton pump inhibitors, and a low-salt diet. Now, right now, our clinical goal for proteinuria is to get it below 500 milligrams. In fact, that's the definition of a complete renal response, getting to below 500 at 1 year. A renal remission is getting back to normal, less than 200 milligrams. It's no surprise when Maria de Lara analyzed the trial data from the mycophenolate studies that those people who had a very rapid resolution did best. The sooner we turn off the inflammation, the fewer nephrons and podocytes will be lost. But there's a problem. We've had a blind trust in proteinuria, and it turns out that protocol renal biopsies have shown that 30% of the time when the proteinuria is under control, there's still histologic activity. If the treatment is tapered and the NIH activity index is 2 or higher, all the patients will flare. Now, I don't know if I can convince you to do frequent kidney biopsies. They would definitely change the approach if we discovered more active disease, because we would either increase immunosuppression or start questioning the patient about adherence. Sometimes there could be good news that the kidney looks pretty good, it's just the proteinuria is lagging behind. Sometimes we get a real shock and we discover another kidney disease. Now, it's really bad news, of course, if we discover the patient has FSGS. Sometimes, though, I discover new diseases I didn't even know about. So one of my patients had an anti-malarial nephropathy. I didn't know that existed. So I cured her proteinuria by stopping her chloroquine. And I had another patient who had an acute interstitial nephritis from one of her hypertensive medications. Now, of course, it's also very bad news if we discover class 6 or the glomeruli are all scarred. In that situation, we reduce the immunosuppression, leaving just enough to control the extrarenal lupus activity, and we start to try to preserve the GFR as long as possible. Now, if we did do more kidney biopsies, the risk is low. It's only a 3% chance of having a hematoma. The risk factors for that are pretty obvious: low platelets, severe hypertension, uremia, because a small scarred kidney doesn't close up the way a sponge would after a kidney biopsy, so things can ooze. And of course, if the patient has antiphospholipid syndrome, we would bridge them with low molecular weight heparin before and after the biopsy, but there can be bleeds when the anticoagulation is resumed. Now, it would be much easier if we could monitor the histologic activity through a non-invasive means. And everyone has hoped we could do this through urine biomarkers. My group, for example, has been working on this for 25 years. The problem is that when you look at one marker at a time, it's highly unlikely that you're going to come up with anything that would be useful clinically. So the field of omics, large data, is really turning this around. Now it's possible to measure 1,000 proteins in the urine with one platform. Using this, my colleague Andrea Fava and I have found that there are highly correlated urine proteins with the simultaneous kidney biopsy activity. And 3 of the top candidates are interleukin-16, TGF-beta, and CD163. CD163 is made by macrophages. And you can see in the graphs on the upper right how highly these correlate with the NIH activity index. We were particularly interested in interleukin-16. No one knew before that it was even a player in lupus nephritis, because it's not associated with proteinuria. So it might be a way to pick up very early lupus nephritis before the urine protein goes up. And Dr. Fava and his colleagues in renal pathology have been able to show that the interleukin-16 is coming from multiple cells in the kidney, as you see in the myeloid cell lines that are plotted in the violin plot on the right. So this is coming from the kidney. It's not coming from the bladder or somewhere else. So we are tracking what's happening in the kidney, non-invasively in the urine. So stay tuned. This is my great hope for the future, is we will be able to come up with a battery that will be very clinically useful. Now, of course we treat lupus nephritis, but obviously our treatment is inadequate given the high frequency of end-stage kidney disease. So these are the 6 different things we do. The first 5, we better be doing those automatically. What's different now is we have 2 new approved therapies, and we have to figure out where are they going to appear in our treatment paradigm. So I'm suggesting that we must have a new paradigm. It used to be you did the biopsy, you started mycophenolate or sometimes cyclophosphamide, and then kind of at a year you decided how people were doing. Well, that's what isn't working. So now I want to suggest to you at the time of the biopsy, if the biopsy is very active, right then and there, you could add other things. You could add a calcineurin inhibitor, or you could add belimumab. Now at 3 months, if there's not a 25% reduction in the proteinuria, you could add the calcineurin inhibitor or belimumab then. Now if there's no improvement at all, you might want to switch to cyclophosphamide. The same exact decisions can be made at 6 months. But don't wait till 9 months or 12 months. Then that patient is already a chronic kidney disease patient. So we're going to have to be braver about using multiple therapies, what's called multi-target therapy. And we need to be so brave that we even do this at the time of biopsy if it is a bad biopsy. Now, what do our guidelines say? Well, our guidelines are way behind the times, aren't they? But I wanted to circle in red that the EULAR guidelines did mention using a calcineurin inhibitor at the time of the biopsy. So that's better than the ACR guidelines, but still, even EULAR or KDIGO guidelines, for that matter, have not really incorporated the 2 new therapies adequately. Now, how much prednisone? Well, of course, you know how much I hate prednisone, so my answer is as little as possible. And if you've biopsied the patient very early, when they just have 500 milligrams of protein, if the biopsy does not show a high activity index, why do you need to have any prednisone at all? Why not just go with your mycophenolate, or perhaps you're a urolupus person or an azathioprine person? But I don't think you need prednisone for everyone. But what if it is a bad class 3 or class 4? The ACR guidelines were very top-heavy in steroids, saying that you could use 1 milligram per kilogram a day. I much prefer the EULAR guidelines, which top off at 0.5 and are very clear that you have to taper to 7.5 milligrams or less by 3 to 6 months. Now, these were actually the guidelines used in basically designing the Aurinia trial of voclosporin. So patients with proliferative LN entered on just 20 milligrams of prednisone. And of course, this trial worked. So please, if you're giving more prednisone than that, change your behavior. Now, I mentioned that our current gold standard is to try to hit a complete renal response at 1 year. But I want to show you that that's inadequate. So this is the 10-year follow-up of a plasmapheresis LN trial. You can see on the right, if the patient was a non-responder at 10 years, nearly everybody was on dialysis. But even for the responders, almost 60% were on dialysis. Only the people who had reached a renal remission were almost guaranteed not to be on dialysis. So remember, we really should be aiming for 200 milligrams or less. It's just our therapies have been inadequate to achieve that. So I want you to rethink your whole approach to lupus nephritis. You want to reduce inflammation. That's often going to take multi-target therapy. At the same time, we need to reduce fibrosis, because ultimately, why are we bothering to treat lupus nephritis? It's because we want to prevent end-stage kidney disease. Now, right now, we all thought that you just get the protein down and that's going to accomplish both of these goals. But remember, that's too simplistic. You can get the protein down and there may still be histologic activity. But I, unfortunately, now have proof in our own cohort you can get the protein down and patients can still march in to end-stage kidney disease. So what is new, and how is that going to affect both the reduction in inflammation and the reduction in fibrosis? So let's first take belimumab. You're aware of belimumab because it's been around for over 10 years for non-renal lupus. The lupus nephritis trial was 2 years, and the comparison group was either mycophenolate or urolupus cyclophosphamide. At 2 years, using the complete renal response definition of 500 or less, there was a 10% delta. So this therapy does reduce proteinuria. You can see on the right, using a complete renal response, that's a little less than 10% at 1 year, and then at 2 years, 10%. Importantly, in the subset analysis shown in this forest plot, belimumab was favored for every subset except for class 5. But remember my 2 goals. It's really important to protect the GFR. And although this graph was relegated to the appendix in the New England Journal of Medicine article, I think it's one of the most important messages from this trial. Starting by 20 weeks, belimumab protected the GFR versus the standard therapies of mycophenolate or urolupus cyclophosphamide. Now, in addition, you will remember Professor Anders' rules. We can't let the patient have another renal flare because 1/3 of the nephrons will again be lost. And so another very important result from this trial is that belimumab protects against renal flares. And the subset analysis showed this was true in every subset, including class 5. Now, what else will we have available? There may be a much better B-cell depleter than rituximab coming down the pike. This is the phase 2 trial. This was called Nobility, and you see the remarkable delta on the right. The phase 3 trial is underway. Now, why didn't rituximab work? It was because it often did not completely B-cell deplete, and the remaining B cells basically reproduced, bringing the lupus nephritis back. Here is the 1-year phase 3 trial of the new calcineurin inhibitor voclosporin. It has better pharmacokinetics than tacrolimus, so it's dosed just twice a day and is not necessary to measure peak and trough levels. The comparator here was 2 grams of mycophenolate. This works fast. Think of this as a powerhouse against proteinuria. Proteinuria goes down starting at the first month. And in fact, what you see at the 52-week complete response are excellent, almost double results versus mycophenolate. Here, the point estimates favored voclosporin in all the subset analyses, including class 5. It worked in all ethnicities and races, but it is a calcineurin inhibitor. So if there is a reduction in GFR, there are rules on how to reduce the voclosporin dose. Now, new things that will be coming. There's great interest in using an interferon blocker. This is anifrolumab, approved for non-renal lupus. In the phase 2 trial overall, there was no significant difference. But in the subset that got a high-intensity regimen of anifrolumab, there was numeric benefit. So we will need to wait and see the phase 3 data. It may also be possible to target the immunoproteasome to get plasma cells. This is safer than just a proteasome inhibitor, but in this phase 2 trial there was no comparator. So although the percent of complete renal response looks very good, without a comparator we'll not know the delta. So we have to wait for a more complete phase 2 for this one. Now for the patient who's dying in the ICU, we need a therapy that's going to save their life and shut down the lupus very quickly. Here is a study of one patient, but published in the New England Journal of Medicine because it was very successful. This used CAR T targeting the B-cell antigens like CD19. This patient had multi-system disease, including lupus nephritis, and within 1 month, basically everything was gone except for a little bit of anti-DNA. But this is, of course, too toxic for our average patients because, of course, people can die with CAR T therapy or become permanently hypogammaglobulinemic and have problems with infection. So we need to refine this before it would be ready for our patients. So I wanted to end this overview on lupus nephritis by thinking about the suffering of our patients, and that's why I wanted to show the face of Saint Sebastian in this beautiful painting by El Greco. But also I wanted to remind you about the multifactorial problems that our lupus nephritis patients face. So the arrow in his lower right abdomen, that might be hitting the kidney. But the arrow in the arm may be hypertension. That's an independent risk factor for end-stage kidney disease. There are 2 arrows in the heart because lupus nephritis increases the risk of cardiovascular disease because, of course, lupus nephritis increases hypertension and hyperlipidemia, doesn't it? So we must treat all of these things if our patients are going to survive. But perhaps one of the most optimistic messages in lupus in the last 2 years has been this explosion of new therapies and new knowledge about lupus nephritis. I thank you for your attention, and I will be ready and willing to answer all your questions. Thank you.
Thank you, Professor Petrie, for such an enlightening talk and covering all aspects of renal lupus. Now we move on to our next talk of the session 2. That would be by Professor Leonard Calibres. He is the chair of clinical immunology at Cleveland Clinic, and he is a professor of medicine at Cleveland Clinic, Lerner College of Medicine, Case Western Reserve University. And he will be talking on COVID-19 and immune-mediated inflammatory diseases, what rheumatologists want to know.
First, I'd like to thank the organizers of this meeting, of this Silver Jubilee, for the invitation to speak. Secondly, I'm particularly happy to talk about COVID-19 because of the challenges and because it will be an enduring challenge for all of us around the planet for the rest of our careers. I'm going to talk about a number of topics in a very high altitude way, emphasizing what I think rheumatologists want to know and need to know. Talk about pathogenesis at a very high altitude, and then focus on what it means to our patients. I'll try to define who are the most immunocompromised and outline a strategy for treating them, diagnosing them, getting them into a circle of care. And finally, I'll talk about the influence of COVID-19 on autoimmunity and the specter of long COVID or post-acute sequelae of COVID-19. This is a figure that we have been working on for several years now, and it outlines the pathogenesis of COVID-19 in a way that I think most people understand. It's three parts. Stage one is when we encounter the pathogen, and you can see the viral load is high. It's in the upper respiratory tract. It triggers the innate immune system. We trigger an interferon response. It's successful or it's not successful. And then, in most people, the infection takes hold, and within a week or so, we start to engage the adaptive immune system in stage two. And virtually all patients have the documented presence of a full house of IgG, IgM, and IgA antibodies. And we start to engage T cell responses, 100% CD4, about 80% CD8. And within a few weeks, the vast majority of people have overcome the infection and are in a recovery phase. Now, on the right, there's a list of risk factors dominated by age and comorbidities, and we also have immunosuppressed states that make people vulnerable to going to stage 3, which is a hyperinflammatory stage that we're still coming to understanding of, but it involves cells of both innate and adaptive immunity, particularly T cells, immune dysregulation, hyperinflammation, and it has features reminiscent of cytokine storm-like illnesses, but it is distinct. Now, with this model, we outline therapeutics that may be beneficial, including those that bolster innate immunity up front and early viral defenses. Interferon trials have been largely disappointing thus far, but early intervention with antivirals, which I'll talk about later, and monoclonal antibodies or serotherapy have had varying degrees of success. But if patients ultimately wind up with phase 3, now we enter in with immunomodulatory drugs that rheumatologists are quite familiar with. Dexamethasone is the standard of care worldwide. The use of IL-6 inhibitors or baricitinib or other JAK inhibitors for patients with more severe forms of the disease. And only in the past week, we've seen 2 positive trials from the NIH on abatacept and infliximab. I won't be talking about it, but I'll answer questions if you'd like to. How will this pandemic end? Well, no one knows, but it is quite clear that it is not going silently, and it will be with us probably in some type of endemic fashion. It will continue to evolve structurally with more variants and subvariants, and we don't have any way of predicting what the virulence of this will be. I think that there will be 2 epidemics, that of the vaccinated and healthy, where they will have low mortality and hospitalizations, and then the unvaccinated and the immunocompromised. And that may include patients with very elderly, immunosenescence, multiple comorbidities, but our patients as well who are on biologics, targeted synthetic therapies, conventional DMARDs, autoimmune diseases, and comorbidities. If we try to define immunocompromise, it's very difficult because it is highly individualized. This is a statement from the CDC, which I really do not endorse, but it shows the vagaries of this. But we know that people on high doses of prednisone, antimetabolites, alkylators, B-cell depleting agents, all are at the highest rung of this group. Now, if we ask the question, when patients with our diseases, immune-mediated inflammatory diseases, particularly rheumatic diseases, get COVID-19, what factors are associated with death? These are data from Strongfeld and colleagues from the Rheum COVID Global Alliance, which is now closed down, which told us very early on that conventional risk factors, diabetes, hypertension, obesity, are risk factors for disease progression. And thus, this requires a great deal of respect. They also demonstrated that having active disease, active rheumatic disease was a risk factor for disease progression. Many of these risk factors are unmodifiable, but this study by Jeff Sparks and Zach Wallace at Mass General and Brigham have informed us that drugs are a statistical risk factor. And the two that fell highest, rituximab, which has been demonstrated time and time again, and is probably the leading risk factor within rheumatic diseases, and a hint that JAK inhibitors at the onset of COVID-19 may imply risk, although the numbers are quite small. So if we asked to summarize, what are the risk factors associated with hospitalization or death in patients that we see? Well, rituximab is at the top of the list, high-dose glucocorticoids, multiple immunosuppressives. Active disease is a risk factor, and thus we need to control disease, maintain therapies whenever possible, and be vigilant for new onset COVID-19 in our most vulnerable patients. Vaccines have been put in billions of arms around the world. And the question is, what is the standard for vaccine therapy? I won't even attempt to do this. I'm really not facile with what's going on in your country and immediate environs, but we do know that complete vaccination with either a single vaccine designed to be a single vaccine or mostly two vaccines for those, the vast majority of mRNA and viral vector vaccines is inadequate. While full vaccination provides enduring protection for severe disease manifestations, it fades in our ability to reduce the incidence of infection after a number of months. In Western Europe and the United States, boosters are strongly endorsed, as I am sure they are in your environs as well. How many times depends upon availability and technology. I'm very sensitive to the availability of medications and the imbalance throughout the world. So anything that I'm talking about in terms of recommendations, I appreciate that it is not equal in all countries, and I'm happy to parse this in the question and answer period. There have been hundreds and hundreds of studies looking at the influence of our diseases and our therapies on vaccine responses. And the only, the most reproducible of all of these find the following findings. One, most patients with rheumatic disease respond in terms of seroconversion. But even patients on monotherapy, single biologic therapy, non-biologic DMARDs, the response appears to be of shorter duration than in patients who are matched controls. Secondly, among therapies that inhibit the vaccine response, at the top of the list are those on B-cell depleting agents, rituximab and rituximab biosimilars, and other B-cell depleting agents are by far the highest. Antimetabolites, and particularly drugs like mycophenolate, which so many of our patients are on, lupus and interstitial lung disease and other conditions, are also. Doses of prednisone, particularly those exceeding low dose ranges, also have an effect. But even, as I said, monotherapy, recent data by Georg Schett show that even drugs such as the 12, 23, 17s foreshorten the duration of these responses. The consequence of having an immunocompromised condition and being on immunosuppressive therapy is breakthrough infection. And we do know that our patients are more vulnerable to breakthrough statistically than age and sex-matched non-rheumatic disease controls. And this was a large study done in the United States, showing at the top, at the bottom, the gray line is breakthrough in the general population. All the other lines, includes one with rheumatoid arthritis, are showing higher rates over time of breakthrough, and the yellow line are transplant patients who are on complicated regimens, including antimetabolites and glucocorticoids and calcineurin antagonists. The issue is not just breakthrough infection, but they have a higher rate of death, and we're starting to learn a higher rate of post-sequelae. This is a recent study of ours, which is now just coming into print. It's been online in Arthritis and Rheumatology, where we looked at nearly 1,700 patients with immune-mediated diseases who were on B-cell depleting therapies, and found that among the breakthrough patients, and this is all pre-Omicron, which was at 4.4%, an astonishing 40% essentially required hospitalization, with 15% in the ICU and 8% dying. This is unacceptable. This is serious, and shows that we need strategies for this. More recent studies and studies done in UK have shown somewhat better results. I think this study also included multiple sclerosis patients. Most of the rheumatic disease patients had vasculitis. We're trying to sort out the differences. But B-cell depleted patients, when we use these drugs, are a warning sign that we need to have a strategy. This is the strategy that we endorse for outpatient management of COVID-19, and this will endure. This is going on now. It will go on next year. It will go on years from now. That is the prediction of most people in this space. You know, the healthy and vaccinated, maybe they're not going to have to worry about this. It'll be like other respiratory pathogens. On the other hand, it could mutate to a more pathogenic version. But our patients with immunocompromised states will be continuously vulnerable. We believe that this circle of care, which we think works in every country, begins with education. And that education is not only of the practitioner, that we know how to manage this, but of the patient for early disease recognition. As drugs come into line and become more affordable, the use of monoclonals as an outpatient has been very effective, particularly those with humoral immunodeficiencies, and antivirals, as they become more readily accessible, should be used and used early. There still will be a role for non-pharmacologic interventions, testing mass social distancing among the most vulnerable patients. And all in all, this requires a system. What do patients need to know? Well, you know, patients who are immunocompromised, who are confronting this, need to know that every time that they start sneezing and have a scratchy throat, a headache or chest congestion, this is not a cold, and they shouldn't be using home remedies, and their primary care doctor shouldn't be giving them, you know, a macrolide empirically and waiting to see what happens. The most vulnerable patients need early testing, and that has to be achieved. If it can be done in the home, patients on rituximab should have home testing available to them. Secondly, they need to know that when they're really sick, they need to go to acute care if they can't breathe and talk. It's too late for that. Thirdly, they need to know who to call. If they're a patient with multiple sclerosis, cancer, or severe lupus or ANCA vasculitis, they don't need to call the primary care doctor. They need to call the specialist, hopefully, who is also educated and knows what the standards of care are in your area at this time. There are many options out there, but they are highly changing and very rapidly. You know, in our area, you know, the options for outpatient management are triaged. Not everybody gets them, but as they become more available and less expensive, you know, the list is long. But at the top of the list are B-cell depleted patients, patients on rituximab, cyclophosphamide, high-dose prednisone, mycophenolate, all of these people. The options are antiviral therapy, and the two that are available are Paxlovid, a combination of nirmatrelvir and ritonavir and molnupiravir, a second-line agent, and monoclonals. And I'll talk about monoclonals in a second. All of these have to be given within a window ranging from 5 days from antivirals to 7 days of the monoclonal for them to be effective. Antivirals, I think, will be the next wave, and these are just the first two. Hopefully, within a year, we will have more affordable and better antivirals than these drugs. These are fraught with some difficulties. They have to be used within a 5-day window of diagnosis and symptoms. Paxlovid, because of its ritonavir pharmacologic enhancer, has numerous drug-drug interactions that have to be perused and critically appraised before giving it to a patient. And then, as you're probably already hearing, even if you haven't been using it, they're not perfect. And a given percentage of patients will relapse after this. Fortunately, it doesn't impair the integrated immune response, and patients still continue to get better. Probably one of the greatest advances in the treatment of a specific pathogen has been the use of pre-exposure prophylaxis. This is the pivotal trial for the drug that we call Evusheld, tixagevimab and silgevimab. It's very hard to keep track of all these monoclonals, which is given as an intramuscular dose for those people who are least likely to respond to vaccines. And how you triage that in your area is individualized. But we put patients who are humorally immunodeficient, B-cell depleting patients at the top of the list. Also patients on advanced therapy for transplants and advanced hematologic cancers as well. And in the pivotal trial of this called PROVENT, it clearly demonstrated that one intramuscular injection of this could protect patients from incident infection and, more importantly, the severe infection and its complications for up to 6 months. It's FC modified to not only extend its pharmacologic half-life, but to reduce its FC binding and the chance for inflammatory complications. In our institution, we give vaccines to all of our patients who are immunocompromised, but for those at the highest level of risk, including rituximab, mycophenolate, all of them we try to offer Evusheld to. And if you're using anti-spike proteins like are done in many countries, those that have failed to respond may be a better way and more cost-effective way to triage this. This was just published a few weeks ago in RMD Open. This is our early experience with this, using this circle of care, advanced care pathway, where we had nearly 400 plus patients on Evusheld, and among these, we tracked the first 12 patients who have very high risk immunocompromised states, who were given this and treated aggressively in an outpatient. And of these, 11 patients had very mild outpatient disease. One patient was hospitalized but was complicated by a disseminated cancer. And overall, the early experience is very, very promising. So maybe this will be the way that we will be going as these drugs become more available. Now, as the drug is available, these are patients that we have at the high end of our list: rituximab, cyclo, myclophenolate, common variable hypogamma, patients who have multiple comorbidities, and patients not likely to need Evusheld, methotrexate, leflunomide, AZA, monotherapy with biologics. We're all good on that. Finally, let me also say that we are very concerned about evolving variants with monoclonals, and every company that makes them recognizes this. And you need to know what monoclonals are available in your area and what the variants are in your area, because this restricts the efficacy. Just a few mutations in the critical binding region of the monoclonal can take these effectiveness of these drugs out. Virtually every company, including AstraZeneca, who makes Evusheld, are working on follow-on monoclonals for emerging variants that hopefully will bypass this critical Achilles heel in these drugs. Finally, what about the continuum? You know, while most patients get better from COVID-19, there is the notion of long COVID or post-acute sequelae of COVID, which means that it is a condition which is the consequence of the original COVID-19. It is still a work in progress. It lacks a uniform definition, but the CDC on this side of the pond, the World Health Organization on the other, suggests that symptoms persisting more than 1 month to more than 3 months, which I think is a more realistic benchmark, should indicate the likelihood that these symptoms may be due to a post-COVID sequelae. Not all patients who have fatigue, breathlessness, chest pain, musculoskeletal pain after COVID have this. They require a vigorous diagnostic workup, but we are seeing that the epidemiology of this shows that it is not uncommon. It is also clinically heterogeneous. This is one of the most widely quoted patients, I think, because of this figure, which recognizes that the symptoms of people after COVID are highly varied, dominated by fatigue, headache, neurocognitive dysfunction, breathlessness, chest pain, and musculoskeletal pain, among many, many others. Symptoms like anosmia and ageusia are largely dissipating as we segued from Delta to Omicron. But it is a highly heterogeneous state, and it can be relatively mild, it can be moderate, and it can be severe, taking people out of productive lifestyles. The efforts right now are underway to try to make some sense of this using machine learning, searching for biomarkers, clinical approaches to managing such patients. And they have focused on a variety of endotypes. I think the ones that we see the most in our long COVID clinic are those dominated by fatigue with post-exertional features, those dominated by brain fog. It's a kind of a pejorative term, but yeah, I think we all understand that it means it is not dementia. It is a loss of executive function, short-term memory. Autonomic dysfunction, a phenotype which has many features consistent with POTS, where there's orthostatic stressors leading to palpitations, lightheadedness, and beyond. A pain endotype, and exacerbation of neuropsychiatric features. This is not a disease that is so-called in the old school psychosomatic. It involves mind and body. It involves brain and immune system. These are single organs. This is not Cartesian biology. I think most of us are understanding this. This is a study that was published from Harvard showing a detailed clinical endotyping in a large group of patients being followed for this, showing that fatigue with post-exertional malaise, meaning that overexerting, even daily activities, can put patients into a crash and burn for days to weeks. Neurocognitive dysfunction, and then sensory motor pain, etc. In 2015, the Institute of Medicine in the United States had proposed criteria for what we still call MECFS, a highly controversial and poorly medically unexplained condition, chronic fatigue syndrome, saying disabling fatigue greater than 6 months with unrefreshing sleep, this post-exertional malaise, something that we don't often ask about, and then either neurocognitive dysfunction or dysautonomia. When these criteria were applied in the long COVID clinic at Stanford by my friend Dr. Hector Bonilla, 52% of nearly the first 100 patients met this criteria. So I will say that a chronic fatigue-like picture is not uncommon sequelae for this. With that very, very brief overview of long COVID, I think this is where rheumatologists become more interested, because the putative pathophysiologic mechanisms that belie it are complex, fascinating, and some quite familiar to us. There's a growing hypothesis of some evidence of persistent viral infection or remnants of viral infection that may be driving this. There are biomarkers that have not been validated across studies, but suggest ongoing inflammation and upregulation of certain cytokines, particularly an interferon signature. There's evidence of reactivation of other latent viruses like EBV. There are microbiomic changes and hypercoagulability that may be contributing to it. And clearly, patients with COVID-19 have activation of what many have called the autoepigenome, which is a pouring out of antibodies to a variety of cell surface markers, the significance of which are unclear, whether they're drivers or passengers, and other unknown mechanisms as well. The treatment of these patients right now is to make an accurate diagnosis. We don't just assign it to long COVID. There are no approved therapies, but we treat symptoms. We can treat autonomic dysfunction. We can treat intercurrent mood disorders and sleep disorders. There are about 30 randomized controlled trials going on. There are interests in drugs such as antivirals and rehabilitation. And rehabilitation has to be done in a highly individualized way. Pacing, which is used for MECFS, which takes people at their own level, doesn't try to push them in a graded way, all have been effective. We've just published this in Arthritis and Rheumatology. If you want to get the executive summary of what I'm telling you today, this is the evolving role of the rheumatologist in the care of immunocompromised patients with COVID-19. It has to do with prevention, getting our patients vaccinated, educating them on the risks of COVID-19, the circle of care that I talked about in outpatient treatment, and finally, education. We will be confronting this for the rest of our careers. This has to be incorporated into meetings like this. This is a 30-minute talk. I've just put on an entire course for practitioners treating autoimmune diseases on COVID-19, and I will continue to do so until we have mastered this. Finally, I want to thank everyone and remind you that there is nothing and no disease moving faster on the planet than COVID-19. And as Heraclitus told us, no man ever steps in the same river twice, for it's not the same river, and he's not the same man. And I'd be glad to answer questions now. Thank you.
Thank you, Professor Calamities, for an excellent overview of COVID and rheumatology. Now let's move on to our second last talk of the second session. This will be given by Dr. Tom Appleton. He is the Chief of Rheumatology at St. Joseph Health Centre, London Western University, Canada. And he would be talking on updates on biologics and target synthetic molecules, a year in review.
Hello, everyone. My name is Dr. Tom Appleton, and I am very pleased to be coming to you from London, Canada, and also would like to extend my sincerest thank you and gratitude to the organizing committee, to the Pakistan Society for Rheumatology, and Professor Saira Khan, and everyone who has assisted with organizing this particular event. And thank you so much for the kind invitation to come and present to you. I'm very pleased to speak today about the year in review with advances in biologics and advanced therapies in rheumatology, and let's get into what that will be. So, without any further ado, these are my disclosures. And what I hope to cover today is some updates about treatments for psoriatic arthritis. There's been a tremendous amount of development in the psoriatic arthritis space over the past 6 to 12 months. I wanted to speak about TNF inhibitors and their risks for malignancy in psoriatic arthritis, to speak about some new treatments coming for lupus, as well as the role for JAK inhibitors in rheumatoid arthritis in patients who previously had a malignancy or MACE events. I won't have time to get into some interesting updates in the scleroderma field, where it looks like there may actually be a role for JAK inhibitors going forward, so stay tuned for further updates there. And I also won't be able to speak about it, but very excitingly, there's a new approval for the first time in many, many years in the myositis area, with the approval of IVIG for the management of myositis. So to begin with, I wanted to share with you a very interesting late-breaking abstract that was presented at EULAR in 2022 in Copenhagen. And this was from the bimekizumab phase 3 trials program. This is the B optimal trial of patients who are previously biologic DMARD naive and have active psoriatic arthritis. This is a phase 3 trial. Now, what is bimekizumab? It is a monoclonal antibody against interleukin-17, but not just IL-17A, but it actually inhibits both IL-17A and F ligands, which is an expansion of coverage compared to existing IL-17 inhibitors available on the market. So the objective of the B optimal trial was to assess the efficacy and safety of subcutaneous bimekizumab in patients with active psoriatic arthritis who've previously never been on a biologic DMARD. This is a positive trial that hit its primary endpoint and key secondary endpoints. The primary endpoint was the ACR 50, which you can see here on the left, with patients on bimekizumab achieving 43% ACR 50. And there was a reference arm with adalimumab. There's no statistical comparison here because of the study design, but you can see that nominally these are similar response rates for arthritis outcomes on IL-17 inhibition with bimekizumab and adalimumab. However, when you look at the PASI 90, you can see an even greater response with bimekizumab, and perhaps not surprising for an IL-17, there would be such a strong skin response with 61% PASI 90 responses. And in the adalimumab arm, again, nominally a lower response rate to adalimumab. These are the ACR 20, 50, and 70 responses over 24 weeks in this trial. And you can see that adalimumab and bimekizumab had very similar ACR 20, 50, and 70 response rates, and both superior to placebo. Similarly, with PASI 90 or 75, 90, and 100 responses, you can see that there were certainly superior responses compared to placebo, but even better responses for bimekizumab throughout the 24-week study period here, regardless of which skin endpoint you look at. Now, MDA is something that's very important for us in the clinic when managing psoriatic arthritis, and whether or not you're actively noting down the measurement, most of us are trying to follow whether we are seeing a response in the skin and the nails and the arthritis and many different domains of psoriatic arthritis. And so MDA was also achieved in the bimekizumab trial, and you can see at week 16, 45% hit minimal disease activity and almost 50% by the time you got to week 24. We'll learn more about safety as the trial program continues to develop for bimekizumab, but these are only the week 24 results you can see here, and very similar safety profiles between bimekizumab and adalimumab overall. I'll just draw your attention here to bimekizumab having a slightly higher rate of fungal infections. These are mostly non-serious candidal infections, and this is expected on IL-17 inhibitors compared to TNF inhibition over here. Now, B Optimal is only one trial in the program. There's a second sister trial called B Complete, and this is in patients who've previously been on a TNF inhibitor. And I just show this here just for illustrative purposes only. There's no statistical comparison being made. But in terms of ACR 50 responses at week 16, you can see bimekizumab was about 44%, and compared to placebo, the delta is about 34%. And in patients who have previously been on a TNF inhibitor, the delta was actually 36.6%. So very similar indeed, and actually not lower as we would expect in TNF inhibitor non-responder patients. So this is quite encouraging that patients may be able to switch from a TNF inhibitor to an IL-17 mechanism of action and still expect an excellent response rate. So the take-home messages from the B Optimal trial are that dual IL-17A and F inhibition is effective for the management of psoriatic arthritis across many different psoriatic arthritis domains, almost 50% achieving MBA. And this is likely to have similar efficacy regardless of whether they've been on a TNF inhibitor before or not. I think this is particularly important for us in practice. In Canada, we already have access to bimekizumab in the management of psoriasis, and we're waiting to see that we get the same approval for psoriatic arthritis. And certainly our colleagues in the United States are waiting to see what the FDA will do there as well. There are still some unknowns, and of course, we'll learn more about the durability of this response over time as the trials get to longer endpoints and long-term extensions. And I'm also curious to know whether we'll also need to dose increment with IL-17 inhibitors like we do with others that are available on the market, if we'll need to do the same for bimekizumab, but that remains to be seen. I want to stick with psoriatic arthritis for another update here. And this is a study that was done in the Nordic countries, and they have a particular advantage when following patients throughout the lifespan because of the registries that are available in the Nordic countries. So there are some really interesting and well-powered studies that can be done with this particular data set, and this one is no exception. So the objective of this study was to estimate the incidence rates of hematologic malignancies in patients with psoriatic arthritis. Now, certainly we've spent a lot of time paying attention to the risk of hematologic malignancies in patients with rheumatoid arthritis, but in this case it's focusing on psoriatic arthritis and trying to understand whether there are different incident rates of hematologic malignancies in patients on TNF inhibitors compared to those who have not been exposed to TNF inhibitors, and also with the compared to those in the general population. So just looking at the risk of psoriatic arthritis overall. They followed many thousand patients from 2006 to at least 2016, or until they emigrated, died, or developed hematologic malignancy, which of course is the primary endpoint in this study. You can see there were more than 10,500 patients treated with TNF inhibitors in this study and this analysis, and many more thousand who are bio-naive with psoriatic arthritis, all with similar age ranges and sex distributions. So these are the main results here, and we can see different types of hematologic malignancies in the first and second column, and the all hematologic malignancy in the right-hand column. So I'll just draw your attention here first to the comparison between patients with psoriatic arthritis on TNF inhibitors compared to those who've never been treated with biologics, and you can see there's really no difference in the risk for hematologic malignancy. What is interesting though is that in patients who are on a TNF inhibitor compared to the general population, match comparators, there is an increased risk, suggesting there may be an association with psoriatic arthritis. And when we look at the psoriatic arthritis cohort by itself compared to the general population, there is a statistically significant increase in hematologic malignancies in patients with psoriatic arthritis compared to not having psoriatic arthritis. So fascinatingly, there is an increased risk of hematologic malignancies in patients with psoriatic arthritis, and this is not really driven by the TNF inhibitor use. So I found this to be very interesting, and a slight to moderate increased risk for hematologic malignancies, as we also see in rheumatoid arthritis, but now in the psoriatic arthritis population, is particularly important for us to be aware of in the clinic. But there's no increased risk with TNF inhibitor use, which I also find to be very reassuring, because this is, of course, is one of the gold standard treatments that we use to manage psoriatic arthritis. So I want to change gears now and focus on lupus. Now, deucravacitinib is a medication that's in development for the management of lupus, and I'll focus on the Paisley study here, which was a late-breaking abstract as well at EULAR this year. Deucravacitinib is actually a TYK2 inhibitor, so in the family of JAK inhibitors, and it's a small molecule inhibitor, an oral therapy that's taken once or twice a day. Deucravacitinib we already have approval for in Canada for the management of psoriasis, but it's being studied now for the management of lupus. So why would that be? And it turns out that TYK2 inhibition also has a beneficial effect of inhibiting type 1 interferon, which of course is very important for lupus. And we saw the approval of interferon inhibitors, including anifrolumab earlier this year in late 2021, depending on where you live. So TYK2 inhibition may actually be beneficial for lupus by inhibiting type 1 interferon or interleukin 12/23, or potentially other mechanisms of action, which remains to be seen. The objective of this trial, the Paisley study, was to assess the efficacy and safety of deucravacitinib for patients with active SLE, and this is a dose-ranging study. These are the doses that were studied out to 48 weeks in the Paisley trial. Note that it's 3 milligrams twice a day, 6 milligrams twice a day, or 12 milligrams once a day, which is essentially equivalent to the middle dose there at 6 milligrams twice a day. Very interestingly, this is a positive study, hit its primary and key secondary endpoints, which I'll show you in a minute. The SRI-4 response rates at week 32 was the primary endpoint. This was positive at the lowest dose of deucravacitinib, 3 milligrams twice daily. And interestingly, there wasn't an increase in responder rates at higher doses, so no dose response rate, which is very interesting. Similar findings with the secondary endpoints, so the SRI-4 at week 48, as well as the BICLA and the lupus low disease activity state response rates. These were all met, and certainly no dose response as well at higher doses of deucravacitinib. This is looking at the serologic responses, so we can see a reduction in anti-double-stranded DNA levels with deucravacitinib and a recovery of C4 complement levels with deucravacitinib, which all supports the clinical responses that were seen earlier. In terms of safety, TYK2 inhibitors may have a bit of a safety advantage when compared to other JAK inhibitors. Now, of course, that is still being investigated and remains to be definitively proven. But what I'll highlight here is JAK inhibitors have a key key safety endpoint of herpes zoster, and that's because we typically see an increased rate of herpes zoster with JAK inhibitors. With the TYK2 inhibitor deucravacitinib here, we did not see an increased rate of herpes zoster in this study, and that is particularly interesting and does support that hypothesis that there may be a different safety profile for TYK2 inhibitors than for JAK inhibitors in general. So there was a lot of activity in the lupus space again this year, as there was last year, and deucravacitinib was part of the showcase there. It seems to be well tolerated, and we'll be interested to see what happens in the phase 3 development program with deucravacitinib going forward. There was also a very interesting CAR T-cell therapy abstract in lupus, a very early phase 1 exploratory study, but nonetheless shows some early promise and innovation in the lupus area. So we'll look forward to seeing where that goes in the future. Lupus is having a bit of a renaissance. We're seeing quite a few new medications that are hitting trial endpoints, and part of that is because of more modern trial designs. And we're also seeing approvals for medications in lupus, which has been a long time in coming, many years since the last time we had an approval. So I want to spend the rest of our time focusing on JAK inhibitors, in particular in the tofacitinib space. And of course, we know all about oral surveillance. I was very pleased to come and speak to the Pakistan rheumatology community earlier this year and talking about the oral surveillance results shortly after these were published in the New England Journal. So I won't rehash all of the results of that study again here, but I wanted to talk about it in the clinical context of what we do now going forward. Of course, I'll remind you, though, that MACE, major adverse cardiovascular events, were not non-inferior in the tofacitinib groups in the oral surveillance study compared to TNF inhibitors, suggesting that they are not equivalent, in fact, a slightly increased risk of MACE and malignancy events in patients taking tofacitinib. We did not see the same signals, though, in earlier registry studies, and there are many such studies out there. Just showing one example of that here from the Coravitas registry, which used to be known as the Corona registry in the United States. And comparing tofacitinib to other biologic DMARDs for risks of MACE, of malignancy, and of all-cause mortality, there was previously no signal for tofacitinib there. So this is a bit discordant with what we saw in the oral surveillance study. This led people to ask the question, is it simply the mechanism of inhibiting IL-6 that's leading to an increased cardiovascular risk? But if we look at the INTRACT trial from several years ago, we can see that MACE events between tocilizumab, so IL-6 inhibitor, and etanercept, TNF inhibitor, is not different, nor is cardiovascular death, nor is all-cause mortality. So this suggests that JAK inhibition is really not causing an increased MACE risk due to IL-6 inhibition per se. There must be some other mechanism of action in play. So all of this has led to the EULAR updating their recommendations on the management of rheumatoid arthritis, and these were draft recommendations that were reported at EULAR in 2022. There were several rounds of voting on the particular wording, and the key recommendation here is recommendation number 8, that previously said that a biologic DMARD or a targeted synthetic DMARD could be added in patients with poorly controlled rheumatoid arthritis, suggesting that there's equipoise. Either one could be used regardless of the clinical circumstances. So obviously that needed to be revised. And after quite a few rounds of voting, this is what has been modified. So you can see now that JAK inhibitors may be considered for patients with active rheumatoid arthritis, but pertinent risk factors must be taken into account. And they list some of those here, certainly risk factors for cardiovascular events and malignancies and venous thromboembolic disease, and focusing in on patients who are over the age of 65, have a history of current or past smoking or other cardiovascular risk factors, prior malignancy, or prior thromboembolic events. So how do we move forward? How do we use JAK inhibitors in the post-oral surveillance era? Well, I wanted to share some data with you from the Canadian context. And I also wanted to start with a case. So this is one of my patients who's 53 years old, a woman with seropositive rheumatoid arthritis, high rheumatoid factor and ATCCP. She does have hypertension, but she's not a smoker. And she is taking methotrexate, hydroxychloroquine, and has previously failed leflunomide, which are also required to use in our jurisdiction before going on to advanced therapy. And you can see when she came in to see me, she had a high disease activity index and certainly high activity rheumatoid arthritis that required intensification of therapy. So what do Canadian rheumatologists choose as their first advanced therapy in patients with RA who are failing methotrexate? This is data from a survey that we conducted in 2020 and is essentially showing the preferred first-line therapy after methotrexate failure. And what you can see is that tofacitinib is actually numerically the #1 preferred therapy by Canadian rheumatologists, followed by etanercept and adalimumab, and actually several TNF inhibitors. So if you combine those together, TNF inhibitors are commonly used as well. But tofacitinib is the #1 therapy started after methotrexate failure in Canada. This is also borne out in the prescription data. And so this is following prescriptions over the last 2 years. And I'll just draw your eye here to the Health Canada warning issue date, which was around January 2022. And what you can see is by looking at the red line here, which represents tofacitinib, which we've been using in Canada for many years, there really wasn't much of a change in the prescriptions of tofacitinib overall after the Health Canada warning was issued. And we have also seen an increase in another JAK inhibitor, upadacitinib, which is indicated for rheumatoid arthritis and other conditions in Canada. And so we are seeing an improvement, or sorry, an increase, I should say, in prescriptions of multiple JAK inhibitors over time, notwithstanding these new warnings. What's particularly important to focus on, though, in rheumatoid arthritis is that control of the rheumatoid arthritis is very important for many outcomes. And of course, treat to target approaches are the evidence-based approach. Choose a target, aim for it, and continue to change therapies and add therapies on top of other existing therapies whenever the disease activity remains high or moderate and you have not yet achieved a remission or low disease activity target. And this is certainly how we practice in Canada. And why is that? Well, In addition to preventing disability and joint damage, treatment of rheumatoid arthritis is known to lower mortality. And we've known this at least as early as from High on Choi's study in 2002 that showed that even methotrexate can reduce the mortality in patients with active rheumatoid arthritis. And this is largely due to the reduction of cardiovascular mortality. So MACE events are reduced by aggressive treatment of rheumatoid arthritis because systemic inflammation has an increased risk of cardiovascular events. So we know that there's a 70% reduction in cardiovascular events when we aggressively treat rheumatoid arthritis. And regardless of the medication that's used, controlling the RA disease activity is really the most important priority overall. So we have to keep that in mind when we're thinking about our case here. So back to our case. So this 53-year-old woman with seropositive rheumatoid arthritis and high disease activity comes back and she says that she prefers an oral option for treatment and wonders if she can use tofacitinib. So I'll ask you to think about this for a second. Would you prescribe tofacitinib for this patient with active rheumatoid arthritis, knowing that she needs better control of the disease and knowing what options you have available to you? So with that in mind, what is the efficacy and safety profile of tofacitinib compared to patients with who are taking TNF inhibitors in patients with RA? And we'll think about our particular patient in this case. So let's go back to the oral surveillance trial for a minute. It was published in the New England Journal. And if we look at the efficacy data, there's really no difference, and we didn't expect to see one, in terms of the efficacy of tofacitinib or TNF inhibitors. Really, the change in SDI scores are almost totally superimposable over the 63 months in the study. So we don't expect there to be a difference in efficacy. When it comes to safety, we know that that tofacitinib is not non-inferior, so there's an increased risk of MACE and malignancy. But when we parse out the different risks in between groups of patients who may be at higher risk versus relatively at lower risk, patients who are over the age of 65 or ever smoked had an increased risk of MACE events compared to TNF inhibitors, which are down here at 0.93, and the tofacitinib 5 milligrams twice daily at 1.23. But if we looked at the group of patients who were between the ages of 50 and 65, there was no increased risk in MACE events between TNF inhibitors and tofacitinib. And in fact, we couldn't even calculate a number needed to harm, as the incident rate was lower for tofacitinib nominally, not statistically. So this means that there may be different risk profiles, and I think we need to factor that in. And Health Canada has acknowledged this in their warning. So their advice is to use tofacitinib with caution in patients who are over the age of 65 or smokers and have other cardiovascular risk factors, but they don't require us to use a TNF inhibitor first, and it's only tofacitinib that received this warning. So when we think about our particular case, our patient is 53. She's a non-smoker, so she's under the age of 65 and doesn't have multiple cardiovascular risk factors. So her risk is actually likely lower than somebody who's over the age of 65. And in her case, her cardiovascular risk is likely not to be any higher than any other medication, such as a TNF inhibitor, for this patient. So it is reasonable to consider the use of tofacitinib for this patient. Now, I want to change to a different case here to wrap up, and this is now a 76-year-old patient of mine who has longstanding rheumatoid arthritis, multiple comorbidities. She's on tofacitinib, and she actually presents to the emergency room with sudden onset shortness of breath and tachycardia. She's diagnosed with a large saddle pulmonary embolus confirmed on CT imaging. So she has a pulmonary embolus, a VTE event. So what is the most appropriate management in this case? Well, of course, if you have a patient who's presenting with sudden onset shortness of breath or chest pain, usually pleuritic chest pain, unexplained tachycardia, or low oxygen saturation, this patient must go to the emergency room or be worked up urgently for a VTE or pulmonary embolus. And remember that D-dimers in patients with active rheumatoid arthritis will have limited value because typically D-dimers are elevated because of inflammation, which is an acute phase reactant. The management in this case would be to discontinue the tofacitinib and provide supportive care, which often includes hospital admission and anticoagulation until stabilization and likely long-term anticoagulation. So when we looked at the incident rates of thromboembolic events in the oral surveillance trial, certainly there was an increased risk of venous thromboembolic disease in patients who were taking tofacitinib compared to those who were taking TNF inhibitors. And when they did a sub-analysis looking at the baseline covariates that were predictors of the risk of developing VTE, it's no surprise that it was patients who had previously had a VTE that had the highest risk of developing a subsequent PE. So when we think about this in our patient's context, we know that having had a VTE is the main risk factor to predict having a future venous thromboembolic event. So for this patient, we should permanently discontinue the JAK inhibitor and control the rheumatoid arthritis by a different mechanism of action. However, there may be some cases where a patient has failed all other mechanisms of action. And if that patient is continuing on lifelong anticoagulation, then it may be reasonable to consider resuming the JAK inhibitor so long as that anticoagulation is in place to reduce the risk of a subsequent VTE. Of course, all of these have to be individualized to the patient and different risk factors, and we have to treat all of our patients one at a time. So in summary, treating rheumatoid arthritis to remission or a low disease activity target remains our shared responsibility. This is the primary goal in the management of rheumatoid arthritis because we know it lowers cardiovascular risk and mortality risks. And we have many medications available to us to try to achieve the best control of rheumatoid arthritis, and that needs to be our focus. I think it's important that we consider using tofacitinib going forward because it's such an important tool in the armamentarium, but we must risk stratify our patients. So for patients who have few cardiovascular risk factors, who are under the age of 65, have no history of prior malignancy or venous thromboembolic disease, our guidelines and our regulators would all suggest that this could be a reasonable option for some of our patients with active rheumatoid arthritis. And of course, we also need to manage healthcare resources. And in Canada, we have a largely public health system, so cost options are certainly considered, and lower cost options are mandated earlier on in the treatment algorithm than higher cost medications. We're experiencing a transition now to tofacitinib going generic in Canada, and we anticipate that it will be moved up in the treatment algorithm as well. And I believe that will likely reflect a similar case in your setting here in Pakistan. So remember, of course, it's also our responsibility to work with our health regulators, ensure we have the best access possible to all of the medications that we need for our patients with rheumatoid arthritis. And I know you'll continue to keep up that important work, as well as the excellent work that you do to provide the best care possible to your patients with rheumatoid arthritis. So with that, I really want to thank all of you for your attention and for the kind invitation, and certainly the Pakistan Society for Rheumatology for the kind invitation to be here with you today. And I wish you all the best and looking forward to our discussion. Thank you so much.
Thank you, Dr. Tom Appleton, for a nicely presented review of biologics and targeted synthetic molecules. Now we move to our last talk of the session 2, and our last star presenter is Professor John Stone. He is the Professor of Medicine at Harvard Medical School, and he is the Edward Fox Chair of in Medicine and works at Massachusetts General Hospital, and he'll talk about pearls and myths in rheumatology.
Empathy by talking about the hands. So this is a patient who I think very obviously has a symmetrical polyarthritis. You can see the swelling of all of her PIPs quite symmetrically. And the same is true for this patient. If you believe that these patients have rheumatoid arthritis, then you would be exactly right. That is what both of these patients have, seropositive rheumatoid arthritis. But they bring up an important myth that one should keep in mind in the evaluation of a patient with an early inflammatory arthritis, and that is that a symmetrical polyarthritis at presentation is the rule for rheumatoid arthritis. This is not the case. In reality, symmetry of joint inflammation may not be present in early rheumatoid arthritis. There are two other common presentations that one needs to think about. One is an asymmetric oligoarthritis,
perhaps, for example, involving only the wrist for a number of months before other joints become involved. And the other is a migratory oligoarthritis, which I have to say I think is my favorite pattern of joint inflammation to observe. In a migratory oligoarthritis, the arthritis involves typically just one joint at a time, and it changes rapidly from one day to the next. One day it's the wrist, the next day it's the knee, the next day it might be the shoulder. In the cases of presentations like this, either an asymmetric oligoarthritis or a migratory oligoarthritis, serologies for rheumatoid factor and anti-CCP antibodies are helpful and important in making the diagnosis. If those are positive, you've got a good sense of which direction the case is heading. Here's a pearl. Aside from rheumatic fever and rheumatoid arthritis, migratory oligoarthritis should also make you think of what disease. So this is a patient who presented with a migratory oligoarticular arthritis, here involving his wrist. And whenever I elicit this history from a patient, I think about ANCA-associated vasculitis, either granulomatosis with polyangiitis or microscopic polyangiitis. ANCA-associated vasculitis is classic for presenting early on with migratory oligoarticular arthritis. This oligoarticular arthritis favors the lower extremities, and it's quickly forgotten once treatment begins. So the patient may have migratory oligoarthritis for months before diagnosis. Once the patient begins glucocorticoids and other treatment for ANCA-associated vasculitis, the arthritis goes away very quickly, and the patient forgets that they ever had it. But it's important to remember and to instruct the patient to let you know if the arthritis has occurred, because the recurrence of arthritis often is the first sign of a flare. The next myth, and this is one that I well remember learning as a fellow also, is that rheumatoid arthritis improves dramatically in pregnancy. This is not true, and over the past few years some better data about this has emerged. In reality, this is only partly true. Remission, as defined by the DAS-28, occurs really in only about 25% of women who are pregnant and have rheumatoid arthritis. Rheumatoid arthritis flares actually occur in about 29% of pregnancies, and it's partly, I think, or maybe in large part, due to the fact that effective medication for rheumatoid arthritis is often discontinued at the time of pregnancy. It is true that postpartum flares occur in a high percentage of patients with rheumatoid arthritis. I learned this as a fellow, and this has not changed. This is true. Rheumatoid arthritis does tend to flare after pregnancy. A pearl about pregnancy in rheumatic disease. The first step in understanding what might be abnormal in the pregnancy of a woman with lupus is a thorough understanding of what happens in the physiology of a normal pregnancy. So it's often said that normal complement levels during a pregnancy make the likelihood of a disease flare low, but this is a myth. In reality, low complement levels, and this is true about low complement levels before pregnancy predict preterm birth. They also, in the first trimester, predict pregnancy loss. But complement levels are actually an acute phase reactant, and they increase in anywhere between 10 and 50% of normal pregnancies. So therefore, the complement levels may be normal even though a lupus patient is having a disease flare. Trends in an individual patient are more helpful than any significant measurement. So it's very helpful to have a patient's history of complement levels before she becomes pregnant. Complement levels alone, when the patient is pregnant, seldom provide you definitive direction with regard to diagnosis and treatment. Continuing on the theme of pregnancy and lupus, a doubling of proteinuria in a pregnant lupus patient may be okay. And this is because the maternal blood volume increases by 50% in pregnancy. So for women who have lupus and some proteinuria at baseline, proteinuria can double in pregnancy simply as a function of the increase in renal perfusion. On the other hand, a patient with a creatinine value of 1, which we would normally regard as being normal, may be very abnormal in a woman who is pregnant. Again, this is because the maternal blood volume increases by 50% in pregnancy. So there's a physiologic lowering of the serum creatinine level in a pregnant woman. And in a pregnant woman, the creatinine should usually be between 0.4 and 0.7, and a creatinine of 1.0 may be a cause for concern. Moving back now to hands and differentiating the DIP joint involvement from psoriatic arthritis from osteoarthritis. It's a myth that these two entities cannot be distinguished when they involve the DIP joints. The reality is that both clinical features and plain radiographs or other imaging studies may help differentiate them. Clinically, psoriatic arthritis, in psoriatic arthritis, the joints may have a squishy component to them, a squishy feel on physical examination. This contrasts with the bony enlargement that's typical of osteoarthritis. In psoriatic arthritis, nail changes may also be present, and those may be a vital clue. The involvement in psoriatic arthritis may be patchy and asymmetrical. And sometimes it's highly characteristic in psoriatic arthritis for all three joints in a certain digit to be involved at the same time, but to spare other joints entirely. This is referred to as the ray distribution, which is typical of psoriatic arthritis. So here's a young man who has DIP joint involvement. You can see the finger on the left has DIP swelling, but the fingernails of the other fingers show classic pitting, nail pitting, a strong tip to the presence of psoriatic arthritis. This patient's DIP joint was also quite tender to squeeze and had a squishy feel to it. And here's an example of onycholysis in a patient with psoriasis and psoriatic arthritis. Imaging can also be very useful. These hand films show a patient with osteoarthritis. In osteoarthritis, the joints have a gull wing appearance, like a seagull flying away over the sea. And there is new bone developing in the DIP. With regard to psoriatic arthritis, there is a fluffier appearance to the joint and to the mineralization. New bone formation occurs in psoriatic arthritis, here shown in the DIP joint of the second left finger. And there is on the right, in the same joint, the DIP, marked periarticular bone formation at the right second DIP, very typical of psoriatic arthritis. Of course, patients may have more than one disease, and this is a patient who had osteoarthritis, classic Heberden's and Bouchard's nodes, but she also had psoriasis of the nails. She did not, however, have psoriatic arthritis. Continuing on the hands, and a pearl related to Raynaud's phenomenon in systemic sclerosis. Although Raynaud's phenomenon is usually the first symptom of systemic sclerosis, there is one important exception to this. And this is a patient with puffy hands bilaterally. You could see that this patient, you might have difficulty distinguishing rheumatoid arthritis from this patient's underlying diagnosis. The exception to the Pearl is those patients who have systemic sclerosis and who have anti-RNA polymerase III antibodies. These patients very often do not present with Raynaud's phenomenon, and their anti-RNA polymerase III antibodies predispose them to the development of scleroderma renal crisis. So in these patients, scleroderma renal crisis may actually be the disease feature that brings the diagnosis to medical attention. So you've got to think about that when you see a patient with puffy hands. It's also a persistent myth that treatment with an ACE inhibitor prevents scleroderma renal crisis. ACE inhibitors are the best treatment by far. They're the cornerstone of therapy for scleroderma renal crisis, but in reality, they don't work when they're given as prophylaxis. The reality is that the dose of ACE inhibitors used to try to prevent scleroderma renal crisis in patients who are not hypertensive is not sufficient to control the incredible outpouring of renin that happens acutely once scleroderma renal crisis develops. So patients who are on ACE inhibition in an ineffective attempt at prophylaxis tend to develop a more chronic process that is less reversible once it's actually diagnosed. In scleroderma renal crisis, the best outcomes occur in patients with the highest blood pressure levels, but the lowest serum creatinine measurements. So getting to patients when their serum creatinine is low, but when they have a very high blood pressure, means that they are more likely to do well with ACE inhibition. Switching back to granulomatosis with polyangiitis, GPA patients can have lacrimal gland enlargement. They can also have submandibular gland enlargement, and this means that they can mimic some of our other very interesting diseases. So when I see a patient with dacryoadenitis, or inflammation, enlargement of the lacrimal gland, which is usually non-tender, my differential diagnosis is pretty short. I learned that Sjogren's is a disease that can do this, and this is certainly true. So can sarcoidosis. IgG4-related disease can do this, and so can AL amyloidosis because of infiltration of amyloid proteins. But granulomatosis with polyangiitis can also do this, and this means that it can be very difficult to distinguish granulomatosis with polyangiitis from these other entities when other disease features aren't present. This is particularly true with regard to IgG4-related disease and differentiating that from granulomatosis with polyangiitis. So with regard to GPA, it's a multi-organ disease, as is IgG4-related disease. GPA can cause a hypertrophic pachymeningitis. It can involve the pituitary gland, leading to hypophysitis. In the orbits, it can cause orbital pseudotumor and involve the extraocular muscles. It can involve the upper airway with a subglottic stenosis. In the lungs, it causes pulmonary nodules and multiple other findings. And in the kidneys, although it usually causes glomerulonephritis, it can also present with renal masses. And IgG4-related disease can present in these different organs in almost the same way, with a hypertrophic pachymeningitis, with hypophysitis, with an orbital pseudotumor and enlargement of extraocular muscles, with supraglottic inflammation, more likely to occur than subglottic stenosis, as is true for GPA. The pulmonary findings of IgG4-related disease can overlap completely with those of GPA, although cavitary lesions are probably less typical of IgG4-related disease. And IgG4-related disease can present with renal masses, so it is often difficult to distinguish these two. There are also challenges often in interpreting the pathology when trying to differentiate these conditions. Immunostaining for IgG4 does not differentiate GPA from IgG4-related disease. Here is a biopsy from a patient with IgG4-related disease. All of the brown staining cells are IgG4-positive plasmablasts. But in GPA, there can be at least as many, if not more, IgG4-positive plasma cells per high-powered field. So immunostaining does not differentiate these two diseases reliably. And neither does a histopathologic feature, storiform fibrosis, which we classically associate now with IgG4-related disease. Here's a patient with IgG4-related disease, and you can see the swirling fibrosis throughout the tissue enmeshing this lymphoplasmacytic infiltrate. But granulomatosis with polyangiitis can do exactly the same thing. So this feature does not necessarily differentiate these two entities either. You can, however, hang your diagnostic hat on three findings. One, granulomatous inflammation, shown here by a multinucleated giant cell, necrosis, here in a blood vessel wall, and neutrophilic inflammation. The presence of any or all of these, granulomatous inflammation, necrosis, and neutrophilic inflammation, strongly swings the diagnostic needle away from IgG4-related disease, which does not cause these other histopathologic features. These are very typical of granulomatosis with polyangiitis. And the other key to distinguishing GPA and IgG4-related disease is serology. Not elevation of serum IgG4. That does not differentiate these two diseases. There are a lot of diseases that can be associated with an elevated serum IgG4 concentration. But the presence of a positive ANCA, illustrated here by an immunofluorescence stain showing cytoplasmic immunofluorescence caused by antibodies to proteinase 3. A positive ANCA from a good ANCA lab means that the patient probably has ANCA-associated vasculitis and not IgG4-related disease. Pearl, once the diagnosis of IgG4-related disease is established, serum IgG4 concentrations are a good biomarker. This is very true. The serum IgG4 concentration, though it has its pitfalls diagnostically, is one of the best biomarkers we have in the rheumatic diseases. If it is elevated at baseline, it correlates well with disease activity. And in fact, the higher its baseline value, the better the correlation, the stronger the positive predictive value. IgG4 in the blood declines with effective treatment and rises as the disease is becoming more active. Here's a myth. I don't know how much Lyme disease you see in Pakistan, but Lyme arthritis presents only in the summer. That's a common myth in places in the United States where Lyme arthritis is highly prevalent. So a comment, or the reality, is that Lyme disease typically occurs in the early summer months. This is true. So in May, June, July, August, with a peak of new cases in July. That's Lyme disease. But Lyme arthritis is a late manifestation of the disease. It does not occur in primary Lyme disease, typically. And Lyme arthritis can present at any time of the year. Here is a patient with arthritis of the right knee with a large effusion, which is the way that Lyme arthritis typically presents. Moving on to kids. So a pearl. The other thing to think about in a teenager with monoarthritis of the knee is a juvenile spondyloarthropathy. Juvenile spondyloarthropathies, which may evolve into a disease looking like adult ankylosing spondylitis, presents with an asymmetric oligoarthritis, and lower extremity involvement predominates. So if I see a young person, a kid, with a knee arthritis, I think about the possibility of an early spondyloarthropathy, even if there is no back pain or spondylitic symptoms. So the lower joint involvement predominates. Here is a patient with a tarsitis, inflammation of the foot joint. That patient turned out to have a juvenile spondyloarthropathy. So many patients, many pediatric patients with spondyloarthropathy ultimately develop classic ankylosing spondylitis, but their presentation usually involves a peripheral joint arthritis and either enthesitis or uveitis. And even in adults, we see a presentation of a disease that we call enthesitis-related arthritis, or ERA. Kids can present like this too, with inflammation where tendons insert into bone in the Achilles, the elbows, around the knees. This is often profoundly disabling, and it indicates patients who are at higher risk ultimately of developing ankylosing spondylitis. So I'd like to move now to the eye and talk about two useful ophthalmologic acronyms. You will impress your ophthalmology colleagues if you can toss these around casually when referring patients to them. One is chorotic precipitates, or KP, and the second is PUK, or peripheral ulcerative keratitis. So let's start with KP and a pearl related to mutton fat, chorotic precipitates. These chorotic precipitates, which develop on the back of the cornea, are referred to as granulomatous uveitis. But in fact, this is a myth, because the finding of these mutton fat chorotic precipitates, although it's often associated with sarcoidosis, does not always denote granulomatous disease. Sarcoidosis is not the only disease entity that causes granulomatous chorotic precipitates. And in fact, there's nothing to support the notion that these are actually granulomatous. They're never examined under the microscope. Not all KP are granulomatous, and other forms of ocular disease can also cause them. This patient, which we published a case report on last year, actually has IgG4 related disease causing quote-unquote granulomatous uveitis. Now, PUK is a rheumatologic emergency. PUK, peripheral ulcerative keratitis, is often associated with the presence of an occult systemic disease that may be lethal if it is not identified and treated aggressively. So there are two diagnoses that should come to mind when you see a patient with PUK. The first is rheumatoid arthritis. In this setting, the diagnosis of rheumatoid arthritis is usually already known, and the patient has developed PUK after years of aggressive inflammatory joint disease. The other diagnosis, which should not be missed but may be harder to detect or think of, is ANCA-associated vasculitis, particularly granulomatosis with polyangiitis, particularly patients with PR3 ANCA. So for my final pearl, I want to tell you about a 122-year-old man, African-American man with intense inflammatory arthritis and mental status changes. In giving this talk, in preparing for this talk, I thought about a patient I saw a long time ago, and when I was an intern, in fact. And I went back into my notes. I photocopied every single admission note that I did as a patient, and I dug them out of my attic, and I found this patient's history because years after after I admitted him to the hospital, I realized what he had. He would be 122 years old now, were he still alive. But this is my admission note from 1990, from September of 1990, September 2nd, 1990, my third month of internship. So then the patient was an 89-year-old African-American man who had presented with a change in mental status over the previous week and diffuse joint pains. He was not able to give a history. The history was obtained from his nephew, who had always been in close touch with the patient. So the nephew described shocking changes in appearance and mental status of his uncle. The patient barely recognized his nephew, of whom he had always been very fond, and this had occurred only over the past week. The patient had previously ambulated quite well with a cane, but now he was unable to stand, unable to get out of bed. He had, as I wrote in my note, considerable discomfort from joint pains in wrists, hands, elbows, shoulders, and back. He was groaning in pain on the gurney in the emergency room, and he needed a neck brace to keep his head up. When I examined him, he had diffuse joint pains, upper extremities greater than lower extremities, large joints greater than small. I remember his wrists were in particular were exquisitely tender. He was barely able to move his arms because of his pain. Exquisite tenderness in his shoulders, elbows, wrists, and even his MCP joints. And both wrists were quite warm to touch. So, as they say, a diagnostic test was performed. And that diagnostic test was a joint tap. My residents helped me tap his left wrist, and he had about 60,000 white cells, too numerous to count red cells. We looked at the fluid under the microscope ourselves and noted rouleau formation, which I commented on my note. The patient also underwent a lumbar puncture, which was unremarkable, but the joint tap showed many CPP crystals, making a diagnosis of calcium pyrophosphate deposition disease. But it was really only years later, when thinking about this patient again in the context of doing this talk, that I realized he had not only CPPD, pseudo-gout, he actually had Crown-Dens syndrome as well. And that's why he was in such pain and unable to move his neck and needed a neck brace to hold his head up. It's not entirely clear when Crown-Dens syndrome was first diagnosed, but had we thought of that entity back in 1990, we could have confirmed the diagnosis probably with a CT scan of his neck. Crown-Dens syndrome has a dramatic presentation. It can mimic giant cell arteritis and PMR, meningitis, sepsis. All of these things were on the differential in that patient in 1990. He actually underwent a temporal artery biopsy, which was negative. Crown-Dens syndrome often occurs with peripheral joint involvement. A CT or MR is the key to making the diagnosis, and the wonderful thing about this diagnosis is that it is exquisitely responsive to glucocorticoids. Patients feel very much better, very quickly after steroids are started. And with that, I will say again, thank you very much for the honor of presenting at and participating in your meeting in this way, and I look forward to doing my best to try to answer questions. Thank you.
Thank you so much, Professor Johnstone, for an excellent, informative, and enlightening talk. Now we'll move to the next part of our session. We'll start with a Q&A session live with the speakers. Can all of you hear me?
Yes.
Thank you. We'll start with the questions that were asked from Professor Michelle Petrie. The first question is, in refractory and resistant lupus nephritis, is there any data on using dual biologics?
I think we are now in the era of multi-target therapy, and there are multiple potential combinations. Right now we tend to use mycophenolate plus a calcineurin inhibitor, or mycophenolate plus belimumab. But there are many patients in the United States that have such severe lupus nephritis that we are using triple therapy mycophenolate, plus belimumab, plus a calcineurin inhibitor. But your question was specifically about two biologics. And you know, we don't like rituximab anymore for lupus nephritis because in the LUNAR trial, it was no better than standard of care, meaning mycophenolate. I think things will change in the future because obinutuzumab, which is a better B-cell depleter, did very well in a phase 2 trial called Nobility. So once we have phase 3 results, it's quite possible that we will be starting to use obinutuzumab for lupus nephritis.
Thank you. Thank you for a detailed answer. The next question is that why lupus is more severe in males, including renal manifestations. Is there any cause or any pathological mechanism for that?
Well, I think it shows how little we understand about the hormonal causation of lupus. Of course, it's more common in women, but you know, before puberty, the incidence is the same in boys and girls. And adding estrogen in the form of oral contraceptives in the SELENA trial did not worsen lupus in young women. But adding estrogen in postmenopausal women in the form of hormone therapy as replacement did increase mild to moderate lupus flares. So it's so confusing, but I've always thought lupus is so confusing. So most men who have lupus have lower androgen levels. And thinking about it that way, androgen is likely protective against many autoimmune diseases, including lupus.
Thank you. There's another question from you, that how often do you suggest renal biopsy in lupus nephritis that is in remission in order to decide about altering the treatment?
So I am seeing the patients myself, as I know you are. And when a patient is doing well, they don't want to have another kidney biopsy. But the nephrologists have clearly shown that protocol kidney biopsies, meaning you do it even if the patient seems to be doing well, are quite informative because 30% of the time in a patient whose proteinuria is controlled, a protocol kidney biopsy will still show disease activity. And if the NIH histology activity index is 2 or greater, and we taper the lupus nephritis therapy, the patient always flares.
May I take the liberty of asking questions,
yes.
Professor P?
Yes,
Can
yes,
you
yes.
please help me in switching on my video?
Okay,
So
okay. We can give you permission for opening the video.
Professor P, so what a player and what
Video
a
on.
great listening
Video
to
on कर
you. So it is
Video
I
on
think
कर दें.
a great
Professor
opportunity
Ahmed
for
को.
all of us to actually interact with the international faculty like you. When this comes to managing lupus, there has always been a question. So because standard of care might be different in our part of the world,
हो गया
because primarily
बाकियों को भी कह दें.
you as
बाकियों को भी
rheumatologists,
कह दें
we own our patients. We are the ones who are the captains of the ship. But what happens is that at times our nephrology colleagues, they really want to take major decisions. So they don't worry much about somebody with proteinuria in which is like 500 to like 1000 milligram. They don't want to biopsy it. We really have to push them hard. So we really need a biopsy. We even go for biopsy when it's like between 300 to 500 milligram. And we have come up with in our series, in our cohort, that a significant number of these patients actually had a proliferative lupus nephritis. Secondly, I would like to just ask you that what if we don't have so what if we don't have other beta cell, B cell depleting therapies we continue to offer our patients rituximab. So can you please comment on that?
So first, you are correct that nephrology studies have shown that if patients are biopsied between 300 and 500 milligrams, over 70% have proliferative nephritis requiring treatment. I think our guidelines will have to change to encourage biopsies at that lower level. And we have the same problem in the United States that nephrologists often don't want to biopsy even patients above 500. But unless there's a good safety reason, such as an anticoagulated patient, I think we need to push them. But I too do not biopsy patients who've had a recent arterial thrombosis and are on anticoagulation, because I think it's too dangerous to have them off anticoagulation even for a couple of days. Your third question about rituximab is, yes, rituximab does help a subset of patients. We've all seen that. The problem is it doesn't help overall. So when you have access to better B-cell depleters, remember, I don't have access to obinutuzumab yet, but when that happens, I think we'll all want to transition to better B-cell depleters. The reason that rituximab doesn't help across the board is that many people with lupus do not completely B-cell deplete with rituximab. That leaves B cells there, and after giving rituximab, there's an increase in BAFF levels that leads those remaining memory B cells to proliferate, and basically that allows that same bad lupus to reappear.
Thank you.
Thank you. There's another question from Professor Petrie, that as you've told in your talk that their PPIs should not be used. So is there any safety data on proton pump inhibitors used in lupus nephritis patients? As in our part of the country, we have a lot of patients who have H. pylori and we are giving them steroids. So would you like to comment on that?
So my comment is not meant to discourage short-term use of proton pump inhibitors for established indications, such as an acute peptic ulcer disease. But I think we now need to recognize that proton pump inhibitors are one of the major causers of drug-induced lupus rashes and can induce rash in idiopathic lupus as well. And of course, they increase osteoporotic fractures, which are the most common damage that occurs in lupus. And finally, there are very good data on proton pump inhibitors causing an interstitial nephritis that's going to lead to worsening of chronic kidney disease. So I want patients transition from proton pump inhibitors to H2 blockers, which don't have these safety concerns.
Okay, thank you. Another question that I would like to ask from both Professor Petrie and Professor Stone. There is a question that is there any association with elevated IgG4 levels with lupus, especially if the patient has mucocutaneous findings and polyarthritis? And in such patient, would there be any role of biologics like belimumab or rituximab?
Maybe I could take a stab at that one first.
Yeah.
I diagnosed a patient very recently who was referred to me for presumed IgG4 related disease because of a strikingly elevated serum IgG4 concentration. She was a 74-year-old epidemiologist, and my ultimate conclusion was, because she had serositis and a very strongly positive ANA and a positive double-stranded DNA, that she actually had lupus, probably drug-induced lupus given her age and disease manifestations. So IgG4 can occur in a lot of different diseases, and it is not unusual to have elevated serum IgG4 concentration in lupus as well. That's very important to keep in mind. An elevated serum IgG4 concentration does not make the diagnosis of IgG4-related disease. With regard to the use of belimumab in IgG4-related disease, there has been some interest in that. There has still not been anything published, to my knowledge, other than perhaps a case report or two.
So all of John's comments were correct, so I have nothing to add.
Thank you.
Thank you so much. Now I would like to ask Professor Leonard Calabrese. We have a question that in Pakistan we don't have the new treatment for COVID like every usual, as you mentioned. So should we be concerned about our patients who are on MMF or rituximab who have been vaccinated against COVID-19?
Well, as I said in my talk, I'm very sensitive to the inequities of distribution of these medicines across the world. And indeed, while aggressive antiviral therapy, pre-exposure prophylaxis, and post-infectious administration of monoclonals to sensitive variants is effective, if those are unavailable, then you have to look at the immunocompromised population and triage them, at least from a medical decision-making perspective of who is at the highest risk and who's at the lowest risk. I think it's fortunate, as I said, that most patients on biologic monotherapies and most patients on kind of low-grade biologics, and that includes methotrexate, leflunomide, etc., do very well. At the top of the list are patients on B-cell depleting agents, regardless of vaccine status, remain highly vulnerable. And certainly, mycophenolate, both in the context of lupus and in the context of solid organ transplantation, defines another high-risk group. I know Michelle has had a long interest and has done some great work in this as well. So those patients are most vulnerable, and if they don't have pre-exposure prophylaxis, then if there's any therapy available upon prompt diagnosis, including monoclonals, it's preferable, but those patients need very strong non-pharmacologic interventions to prevent it.
Thank you.
Can I ask a question, Lenny?
Yes.
Sure. Nice to see you.
Great seeing you from Metro to Lahore, Pakistan. Hi. I have a quick question. Our patients who are getting, especially patients with vasculitis and maintenance rituximab, obviously every 6 months, we are very concerned for those patients. So what about vaccinating those patients? Because in our case, if they've already done with 4 series of vaccination, do you still repeat them like every 6 months? What do you do?
Those patients should be vaccinated. Knowing that they're vulnerable doesn't mean that they shouldn't be vaccinated. The question is how effective is it? This is a very complex matrix of answers here, but I mean, even using drugs like Evusheld when they're available, it is not a substitute for vaccination. But we know that if you give it within a 6-month window of rituximab, it's almost futile to get an adequate response. So for those patients with RA, recent data by Paul Emery and the Leeds group show that in a highly vaccinated group that is getting, RA-like doses, not vasculitis regimens, they do pretty well. And I'm very encouraged by that. And then lastly, I'll say, since my talk has changed radically in the past 2 weeks since I've taped it for you, I'm very encouraged right now with the reduced pathogenicity of Omicron and virtually all variants of concern. And even in high-risk patients with Omicron, the outcomes are better. So for the moment, we cross our fingers and hope that pathogenicity stays low.
Thank you.
Lynn, I might add that in this era of COVID, we should probably reconsider the notion that all patients with vasculitis, ANCA-associated vasculitis, should be retreated every 6 months with rituximab. Sometimes some patients do need that, but I find that one one can generally space out the rituximab infusions, and I get many of my patients to 1 gram dose of rituximab once a year, perhaps, or even longer. I don't think we need to keep patients continuously B-cell depleted, and the era of COVID has taught us that very vividly.
And I can't agree with you more. And if you can do that and span it out and vaccinate them in that 6 to 12 month window, that does appear to provide good protection. Actually, there was a nice editorial by Terrier and Guillemot on this, saying, that we need to re-examine that, and that, perhaps a more, looking at the PRN data makes much more sense for the moment. And so, good point, John. Thank you.
I would just like to take a time here and ask Professor Nigat, Professor Sumaira, and Professor Ahmed about their experience during the COVID pandemic in Pakistan regarding the patients suffering from rheumatic diseases and on different DMARDs and biologics. What has been your experience in Pakistan in the COVID pandemic?
So COVID during the first year was a nightmare. We didn't know what to do with them, to be very honest. So it was difficult to manage, and people were seemed like they were dying right and left, and it was a very difficult situation for our patients and for us as well. But it seems like after that, now where we stand right now, actually I think we are more confident now that we understand COVID, hopefully better than what we did at the first year, and with the vaccinations, it seems like only very vulnerable patients get COVID and even they recover. So I think with changing therapies, understanding the disease more with vaccinations, although it is very difficult to convince patients to get vaccinated. They do the first, they do the second, they may do the third, but to convince them to do the fourth one is very difficult. So that's a challenge, but I think our bad luck is that we cannot have antiviral therapies and we cannot give them to people who are more vulnerable, and I hope we can do that.
Yes, comments from Professor Sumaira and Professor Ahmed, if anyone of you want to ask.
Just very, very briefly, it's a complete honor to be able to actually speak with all of you in person, because one has to fly across 2 continents and reach ACR most of the time to get to, hear you people. So it's been absolutely wonderful, and thank you for giving us this time and sharing your expertise. I think briefly, my own initial experience was, first one year was terrible, because 6 of my little girls came down to COVID, and despite everything we tried, they just went into a cytokine storm, despair, and we couldn't save them. So that way, it was really heartbreaking. The first year was very, very bad that way. But after that, as Nikhil was saying, I think maybe we got a better hang of it. Probably people started getting vaccinated, that seemed to help. But it's been a tough time for everyone in that. So, other than super patients, we have.
I think Professor Sumaira, Professor Nikhil, yes, feeling is mutual. Pre-vaccination era was really very difficult, but with good vaccination rates, I believe our patients, they have really done well, and that scare is no more there. And the thing is, we have started using less of rituximab for our RA patients in the last 2.5 years, because we already had this thing in mind at the outset that this drug probably is going to be the one which is going to turn out to have the worst outcome, and that actually the data later on showed. And another thing I believe is that we very less percentage of patients they are on biologics, and this might be reason for not that worse outcomes in our patients. But yes, we did lose a lot of patients who were actually lupus and vasculitis patients, especially a few of them, those who were treated with rituximab.
Thank you, Dr. Ahmed. I would like to ask Professor Calabres that in COVID-19 positive patients who are non-critical, what would you recommend about stopping DMARDs in these patients?
Yeah, that's a great question, and the answers are, sea-level data based upon extrapolation, not on hard data. I think in patients with RA and non-life-threatening illnesses, that it's an easy call to hold DMARDs of any sort during the first week or two of the illness. The risks of flare are relatively benign, and taking the foot off the accelerator of immunosuppression seems to make sense. It is, there's two concepts here. We have data that drugs such as JAK inhibitors, IL-6 inhibitors, very recent data on infliximab and abatacept to be highly effective, even in moderate disease. So is this a critical issue to stop these or not? I don't know, but that is what our recommendations have been through ACR, and I still think that they make sense, though. The one exception is TNF inhibitors. There are soft data to suggest that being on a TNF inhibitor at onset of COVID, you actually have better outcomes. So I'm doing a lot of hand waving here because I don't have the hard data for this, but that's what we do.
Thank you so much. And any lead on how to manage patients having long COVID with fatigue affecting their daily lives?
Yes. Okay, you've asked me the question that requires the longest answer.
These are questions
or the shortest answer.
These are from the audience.
We are very engaged in long COVID in general, and we're very engaged in the question of long COVID within the IMIDS population. And there's still many questions afoot of whether our patients get more or less. Does it have the same clinical endotype or a different clinical endotype? For the moment, there are no approved therapies. Treatment is generally supportive, but it starts with accurate diagnosis, because not every patient who's breathless or fatigued or has neurologic symptoms has long COVID. We need to make sure that there's nothing else going on. I'm very encouraged at how things are taking off globally in terms of this, but as our recent Lancet commentary said at the moment.
Okay, thank you so much.
And I say this with all genuine, I'm being very genuine. I think that patients who have this need to be validated, they need to be heard, they need to be supported. That's good doctoring, and there's far more to come on this. I'll be glad to come back and give you the full talk on it as it is. But that's what I think.
Thank you so much. I would now like to ask Dr. Tom Appleton, are JAK inhibitors totally contraindicated in hyperlipidemia?
Thank you so much for the question, and I think you can hear across the panel today, really the theme of the day is risk stratifying patients regardless of the context. And my answer to that question would really be very similar. I think it depends on the context of the patient. Hypercholesterolemia in and of itself is not necessarily the main contraindication, as we learned from the oral surveillance study. It's really about the patients who are over 65, patients who had previously smoked, have a high burden of cardiovascular risk. So, if the patient has hypercholesterolemia, make sure that there's not something else going on that's leading to that. There's a small population of patients who will have a familial dyslipidemia
dyslipidemia, so these things can be investigated. But for the run-of-the-mill dyslipidemia, that can be treated, and certainly tofacitinib can be used, provided those other risk factors are not in place.
Thank you.
Now there's a question for Professor Johnstone, that in a scleroderma patient without scleroderma renal crisis, is there any role of giving ACE inhibitors prophylactically to prevent renal crisis?
So the notion about ACE inhibitors, as I mentioned, is that using them as prophylaxis is not effective and can set a patient up for the development of a more chronic, more difficult to diagnose scleroderma renal crisis. So I think my answer to that question is I would avoid the use of ACE inhibitors for prophylaxis and would use perhaps calcium channel blocker or other things to treat a patient's baseline hypertension that is not clearly related to systemic sclerosis. It's clearly a difficult challenge, though, because that patient's blood pressure needs to be followed very, very carefully. And any change from baseline, any increase from baseline, then you really need to think about intervening quickly with an ACE inhibitor and really push the dose of ACE inhibitor up if you're suspecting scleroderma renal crisis.
Thank you. There's another question from you, that in IgG4 related disease, which tissue biopsy has maximum yield?
So all of the tissues will show the classic pathological features of IgG4 related disease. It's most easy to biopsy the submandibular glands. They can be visualized and palpated right below the skin. It's easy to do core needle biopsy of those, and that should tell you everything that you need to know. But lung, kidney, pancreas, those will also yield diagnostic information. They're obviously just more invasive to obtain.
Thank you. There's another question for you, that does IgG4 related disease affect large or small intestine, and how can it affect that?
One of the striking features about IgG4 related disease is that it very seldom involves the intestine, either the large or the small intestine. We often have patients who have non-specific bowel features, but we really think that the disease spares the bowel by and large.
Thank you.
Thank you. I would now like to ask Dr. Tom Appleton, would you use JAK inhibitors in patients who
I have a question from
Yes, ma'am, you can ask.
Okay, sure. Go ahead.
Sure. Hello. Yes, ma'am, you can ask.
Yeah, hi. Okay, Michelle, that was great seeing you. We were looking forward to seeing you in Lahore, but this is great. Thank you so much for your precious time. I have a question. Our issue with lupus patients is that patients whose creatinine is above borderline, but their urine is totally quiet, no active sediment, and we are stuck with whether this is active disease or whether this is is it like chronic disease? We can't do anything about it. We ask for a biopsy, but our nephrologists are very reluctant to do a biopsy on a patient whose urine is quiet, and they say this is chronic disease and just leave the patient alone. So as the data suggests that we can still find active disease on a biopsy, and there are certain groups who are doing biopsy in the beginning and biopsy at 6 months. That's an overkill, and then another biopsy after a year to see that if there is disease which is not manifest and will show itself in one biopsy. What do you say about that?
The problem obviously is that proteinuria is not a perfect measure of either activity or chronicity. So the biopsy is always going to give more information that you and I cannot possibly obtain from watching over the urine protein as well. So obviously if there's unexpected activity on the biopsy, we can increase the intensity of our regimen. When there is chronicity though, I think now we have an armamentarium. Now, the first, of course, are the simple things like ACE inhibitors or ARBs, but belimumab clearly protected the GFR from 20 weeks onwards in the phase 3 belimumab trial, and nephrologists now are very interested in SGLT2 inhibitors, although we do not have a study in lupus nephritis. They did do beautifully for a proteinuric form of chronic kidney disease, meaning IgA nephropathy. So we have options. And just to throw up our hands and say there's nothing we can do for chronicity is dooming these young people with lupus to a life on dialysis or end-stage kidney disease.
Thank you. So, Dr. Tom Appleton, if a patient has provoked pulmonary embolism, can we give them JAK inhibitors?
Yeah, that's a question that we've certainly come across several times in our center. I think the key thing to remember in the case of a VTE and certainly with JAK inhibitors in the oral surveillance study is the sub-analyses clearly show that having had a previous VTE is the biggest predictor of having a future VTE. And so in the case of somebody who has a provoked VTE, they've already proven that they can develop them, and it's not entirely ruled out that in the future they could have another one if they had another surgery or some other insult that provoked another one. So I think in that case, it's prudent, if it's at all possible, not to use a JAK inhibitor there, and to consider alternative therapy. Certainly in RA, there's lots of alternatives. And then have a close discussion with thrombosis team or whoever's managing the anticoagulation. Most of the time with provoked VTE, the anticoagulation is stopped after 3 to 6 months. And so you won't have that protection in the longer term. So it would be ideal in that case to try to use a different mechanism if you can.
Thank you.
Dr. Saida, may I ask a question here
Yes.
from John? So, John, how about using the CV risk calculators? Are there any cutoff for starting tofacitinib or any other JAK inhibitor? Is there any work done on it?
Sorry, who are you directing the question to? Is that to me or to Dr. Stone?
I
heard John.
To you.
John,
oh, yeah. Okay.
Tom.
Yeah, no problem. Just wanted to make sure. I'm sure everyone here has their takes on these things as well, so it'd be good to get their input. So in terms of risk, I think probably the best again is we have a large RCT that's been done on safety endpoints, so we always want to go back to that. And again, the main risk factors that fall out of predicting future cardiovascular risk are the traditional cardiovascular risk factors, going right back to Framingham. So hypertension, dyslipidemia, ever smoking, age, genetic history, all of those things do contribute to the risk. So, the patients who were included in oral surveillance were over the age of 50 and had at least one cardiovascular risk factor. But certainly there was a dose response, if you will, in terms of risk. So higher number of risk factors, older age, previous smoking history or active smoking are the biggest things. So it would be reasonable to use a cardiovascular risk stratifier, but really it's the burden of those cardiovascular risks that drive whether somebody is going to be at an increased risk compared to a TNF inhibitor if they take a JAK inhibitor.
Thank you so much, Dr. Appleton. Welcome, Professor Jack Cush. There are a few questions that the audience had asked from you. I will begin with, does Still disease coexist with other autoimmune diseases?
There are sporadic reports, but that mainly reflects misdiagnosis more than anything else. It would be really unlikely. Obviously, up to a third of patients with a systemic onset of Still's disease will settle into a chronic inflammatory arthropathy, so you could say Still's can coexist with RA, but no, they do not. I can tell you when I did a review of 23 patients at the University of Pittsburgh many years ago, one of them over time really did declare themselves to be lupus. Another one really never declared themselves to be anything, but the other 21 of the ones were reported in a long-term follow-up series. So no, the answer would be no.
Okay, thank you. And glycated ferritin in Still disease, can it differentiate between Still's disease and infection?
Can ferritin?
Yes, glycated ferritin, can it?
There is research on the use of glycated ferritin, except it's not routinely available. And hence I don't think it has any real discriminatory value. Again, the distinction between infection and stills at the onset, systemic JIA, adult onset systemic disease, can be very, very difficult. And I don't know that there's one marker that would distinguish between the two. The one that someone said LDH, someone said calprotectin. A more recent one, myeloid protein 8/14, as a new biomarker, and I would say aldolase. In my experience, aldolase is very, very elevated with systemic JIA, but should not be elevated with infection.
Do you think there is any dissociation between the level of aldolase and CPK in patients who flare in Still's disease?
Yes, aldolase, no CPK. All patients who have active systemic disease, or what I would call IL-1 responsive disease, in my opinion, and again, this has not been well researched. There's only been like 1.5 reports in the literature and really case series. Aldolase goes up with IL-1 responsive autoinflammatory disease. So it's not unique to Still's. It can be seen in other autoinflammatory disorders. But if you are ordering aldolase, all of us are going to reflect and order CPK. Those are all normal. And this is often at a time when there are other LFTs, AST, ALT, the transaminases are very, very high. The aldolase is coming from liver, not from muscle.
Okay, thank you. There's another question from for Professor Petrie, that you've mentioned about the role of C3 in lupus. Is there any role of C4 in lupus activity as compared to C3?
Some people with lupus will genetically have low C4 levels. But in terms of bad prognosis, it's really low C3 that defines a subset that has a much greater risk, not just of lupus nephritis and end-stage kidney disease, but also cardiovascular events. So I don't like the part of the EULAR criteria that give more points if you have both low C3 and low C4. I think in terms of diagnosis, having low complement is something important, but I don't like low C4 being given more weight.
Thank you. First you ask.
Dr. Stone,
Can I ask a question?
Yes,
Sure.
yes, sure, ma'am.
We used to use Imilan a lot, and I had really 2 or 3 very bad experiences of neutropenia and bone marrow suppression. So scared by those 3 or 4 incidents that we routinely do TPMT levels. Are they available in US? Do you do them if you use it?
So yes, we can, but now the genetic predisposition to azathioprine poor metabolism includes much more than just TPMT. So I wish that there was one screening test that would include all the genetic predispositions. And since there isn't, I would recommend with azathioprine that even if the TPMT is okay, that you start with a low dose and gradually go up.
And do you believe in lupus?
So yes, rheumatoid arthritis is obviously more frequent than lupus. And just as we know people could have lupus plus primary Sjogren's, patients can have lupus plus rheumatoid arthritis. And in that situation, I think the rheumatoid may drive the show, and you may have to use anti-TNF, even though, as you know, I don't like to use anti-TNF in pure lupus, because anti-TNF can increase anti-DNA and anti-phospholipid antibodies.
Thank you.
But I think the data now is coming, the data which actually one of our colleagues has presented, overview of the JAK inhibition, the role in lupus. So that is one potential then therapeutic.
But it's very disappointing because of the 2 baricitinib phase 3 trials, only one showed benefit. And therefore, baricitinib will not have a 3rd phase 3 It will never get approved for lupus. But the way out of this is there was a trial of TYK2 inhibition, a phase 2, which was promising. And TYK2 inhibition may allow us to escape some of the JAK inhibitor side effects that we really don't want to see in lupus, such as cardiovascular events. So I think we're going to have to wait for phase 3 trials of TYK2.
Can I just add to that one? So
yes.
I think you're referring to the Paisley study, Michelle. I was curious what you thought about the lack of a dose response in that study, where the 3 BID and the 6 BID were really not different. If you think that has any weight to things, and to your point, the zoster risk is not increased. I think one of the other questions from the audience was risks being different among the JAK inhibitors. Well, the TYK2 inhibitors don't seem yet, at least, to be showing that zoster risk profile. But just curious about your thoughts about the dose response or lack of.
So I think phase 2 trials in general in lupus tend to be confusing, and this is not unusual not to see a dose response, and this has been true in so many studies. By the way, belimumab, that has been approved for non-renal lupus now for over a decade. Its phase 2 was negative. People sometimes forget how difficult it is with study designs in lupus.
Thank you so much. Now I would like to ask Dr. Stone. This is a question from the audience. A patient, 43-year-old male, who has active seropositive RA, having both RA factor positive and anti-CCP with a high DAS, and is smear positive for tuberculosis, has hepatitis C as well with deranged LFTs. How would you proceed?
So a patient with seropositive RA and active synovitis who has a positive skin test for tuberculosis?
Yes, active tuberculosis, pulmonary tuberculosis, and is also
active tuberculosis.
Yes. Along with, actually we see a lot of such cases.
Yes, I know you see a lot more of that than we see in the United States. Yes. Treating the tuberculosis has got to be the first priority. So
I think the panel is unanimous. Treat the TB.
The only caveat
is many drugs for tuberculosis as you can put him on, and once your ID colleagues relent and allow you to treat him for his rheumatoid arthritis, I would probably start with methotrexate plus minus the TNF inhibitor to treat his RA.
Okay.
Or be old-fashioned. Remember, you can give hydroxychloroquine for RA, and hydroxychloroquine does not increase the risk of any infections.
Yes.
I just don't think it's going to work very well for a polyarthritis that's seropositive. But the first priority has got to be treating the tuberculosis, and I know that you see a lot more of that than we do.
Thank you.
That's what we normally do, though. We do give them hydroxychloroquine, and if they're not having any hepatitis, drug-induced, or otherwise, we just try and give them a low dose of sulfasalazine while they're being treated. But hydroxychloroquine at max doses, then they're over it.
So I have for the whole panel, and Lenny, you also, if somebody has active arthritis and they have TB, and you start treatment for tuberculosis and for hepatitis C, wouldn't rituximab be a better choice because it knocks off the B cells rather than the D cells for such patients?
I would not be going into a biologic in a patient like this at all. And I would start treatment for tuberculosis. I would use triple DMARD therapy, and then I don't know what the availability of direct antiviral therapy for hepatitis C, but that is the standard of care, and I would be trying to get that patient cured within 6 weeks. Rheumatoid is going to be around for a long time. You can kind of palliate with incomplete control. This is not life-threatening, but the infections are, and that's how I would do it.
I would agree with that, and I think the other thing to remember too is that Hepatitis C can cause a polyarthritis that mimics rheumatoid as well, and so treating the hepatitis C and trying to make sure that it is indeed a new rheumatoid and not one of those mimics caused by hepatitis C. Remember, the rheumatoid factor can be quite high in hepatitis C, although in general, certainly most case series that have been published, there's not a lot of great data on this, but anti-CCP tends to be negative in hepatitis C, so that might help differentiate.
Yeah,
Thank you.
anti-CCP would really help in such a situation.
One last question I would like to ask Dr. Kush. We don't have IL-1 inhibitors in our country. What do you think is the role of tofacitinib in adult onset still disease?
Or JAK inhibitors for that sake?
Yeah, I think that certainly you should consider an IL-6 inhibitor if you don't have an IL-1 inhibitor, as they are been well studied and at least FDA approved in systemic JIA. Prior to the introduction of biologics, the management of Still's disease, systemic disease was dependent highly on high-dose steroids and high-dose methotrexate, plus or minus azathioprine, plus or minus cyclosporin, and those are alternative, but there's a lot of toxicity management you have to go through there, and it can be a little scary. But so then IL-1 and IL-6 inhibitors change the landscape. I think now there's a lot of anecdotal case reports of JAK inhibitors being very effective, one in the setting of MAS, but also in the management of acute systemic disease along with the chronic articular disease. But you have to recognize it's all anecdotalism, and that is really what underpins that is going to be a reporting bias. So there was a report at EULAR 2022 that said not all patients with refractory systemic JIA or adult Still's disease are going to respond to TNF inhibitors. I think the number was 40 or 50% of patients who did not respond. So while there's promise there, you're out on a limb if you want to go there.
Thank you.
I have a question to Dr. Kush. Dr. Kush, so in our part of the world, because of helminthic infections, because of tuberculosis, I think positivity low titer for rheumatoid factor, and even because of Hep C, is quite prevalent. And when we start using the criteria which actually mandates negativity, seronegativity for rheumatoid factor, I see that there are few subset of patients who really have a systemic features with a polyarticular course, and they can fit into Still's disease, but just because of that low titer rheumatoid factor, they are classified as RA. Is there something like this you have seen in your practice?
I see plenty of people who other people want to call Still's disease with rheumatoid factor, and they don't meet criteria because they have rheumatoid factor. I'll remind everyone that rheumatoid factor cutoffs on positive values are based on your population norms, not based on the population norms of the United States. So what is a positive rheumatoid factor in your region is accepting maybe a high baseline level of rheumatoid factor and or ANA in your region. Again, this is a syndrome for which there is no clear etiology or diagnostic test. Adhering to the criteria that have been established, that I talked about, or reading the papers of Bywater's and Bujak's, 1971, 1973, you'll learn everything there is to know. To try to, fit that square peg into the round hole of the Still's diagnosis is not, I think, wise. I mean, in essence, you're going to end up treating whatever the dominant symptoms are. What you call it may not be so important in these situations where patients don't meet criteria. But I didn't go into in my talk that if you don't meet criteria, and I do have something on my website about that may be an open door for you to do genetic testing, to look for another autoinflammatory condition which may underlie that particular patient's syndrome.
Thank you. Thank you so much. Before moving on to the concluding remarks by the chair and co-chair, I would request the speakers if they want to give any comment or any view about this course and any other thing that they'd like to comment upon. then we'll move on to the closing remarks. If any one of you wants to say something.
We're all so happy that we could get together in this way.
Yes, yes, we are really excited to see all of you present on this forum. For us, it is a big thing. So we are really happy and grateful that each one of you could come and join this conference.
Any other comment from our speakers?
I just congratulate you on, sorry, go ahead.
No, just our privilege. Thank you so much.
Yeah, I would echo that, and congratulations on 25 years, and hope it's a successful 25 more.
Thank you for the invitation to participate.
Thank you.
Thank you. Now we'll move on to our closing remarks. I would request the chair and the co-chair to give comments, the closing remarks.
Wow, it is, I have attended almost all review courses and ACR meetings, and I have not seen such a galaxy of stars in rheumatology globally who are present here today. What a great kickoff to 25th anniversary Silver Jubilee. And I know Saira, when she was sending emails to everyone, it was like she's not going to hear a no from anyone. And she and Bilal had put up an excellent show. We were 8 rheumatologists when we started the BSR, and now we have almost 100 for a country of 120 million people. And your being here, I don't have words to thank you. Such a precious faculty here who spend their precious time in with us, and I'm especially grateful to first speaker, which was John Kush, and it is fantastic. Kush, you are a celebrity. We have Ruma now. We get those updates, and you can review the latest in rheumatology in the shortest possible way in our busy lives, and so happy that you could spend your precious time with us. And Michelle, we had a promise that you would come to Lahore, with Uzma and all those meetings, and we all hope and pray that we see you in Lahore we do have a small lupus cohort which we are working on, and it's always a pleasure and a joy to hear you, but hopefully we'll see you in Lahore soon, and others as well. Lenny, it's always a pleasure the way, I remember when I was at Metro, you were with HIV and rheumatic disease, and now you're COVID and rheumatic disease, so it's never going to stop. And it was, all these talks were really great, and hopefully, we'll see you here also. And what a nice, I think it was an excellent review, and I'm happy that Canada is using JAK inhibitors, so that's good for us, because when we talk to our patients and we ask them about different choices, they are opting for JAK inhibitors because it's difficult to carry injections, they are more expensive, so that was heartening to know that that is first choice, and I know it's in Australia too. Professor John Stone, what a nice review of those myths and those pearls, and I think I have no words to thank you all for spending your precious time here today. Beautiful. Thank you so much.
Thank you, ma'am.
Ahmad,
Dr. Ahmad,
anything?
A big round of applause for the highly esteemed talks by such an international faculty and for the organizers, so primarily Saira, Bilal, and moreover, we didn't have any IT glitches. Oh, hooray!
Thanks to our IT team. We are extremely grateful to our IT team.
Okay. Thank you
What
so
a
much.
great start for the 25th Silver Jubilee Conference.
Thank you.
Myra, you want to say something? Myra is, I think, disconnected.
No. Can you hear me?
Yeah.
Okay, so I'm babysitting. Actually, I don't know if you can see my grandson.
That's great.
Say hello to you all, and he is in midst of great celebrities out there.
Yeah.
Such a pleasure. What a fantastically constructed and arranged program. Saira, Bilal, the whole organizing committee. I think those, Nathan, Emma, and thank you all so very much for you to have participated in this. It's been such a thrilling pleasure for us. So
Thank
you, and
Thank
hope that we can all meet in Pakistan maybe next time.
Thank you so
Thank
much.
Thank you.
Thank you. I would like to thank all the chairs and co-chairs as well as my esteemed speakers who have been in contact with me for the last 8 months, and I'm sure they are hounded by my emails. Thank you so much for being here and sending us your precious talks and giving us your time. I would also like to thank all the participants who have joined in and asked questions. I would like to thank PSR for allowing us to hold this conference and thinking us capable enough to manage it. I have to thank my Shalimar team who had put through this webinar for me, and thanks to them we are now hosting these webinars. And above all, the person who stole the show today was my audiovisual person, Rausa, who I have been pestering for the last 2 weeks or so, giving him sleepless nights. And he has been amazing today. Thank you so much.
Thank you.
Thank you.
Madam, do you think we can have all the speakers on video so we can take a screenshot with them?
We've taken the pictures.
Yes.
Yes, and we've taken the pictures.
We
yes.
have taken the pictures actually.
Okay, thank you.
Thank you so much. Thank you.
Thank you.
Thank you.
Thank you so much.
Take care.
Bye bye.